Good morning, everybody. We'll go ahead and get started. Thank you all for coming to our Bariatric Update 2025. So we'll go ahead and get started. So first, I'd like to invite Dr. Usman here, and I'll have every speaker kind of introduce themselves for you since we have talks back to back. So Dr. Usman, you want to come in and talk about the scope of obesity and how to talk to patients about obesity.
Good morning, everyone. I'm going to talk about the scope of obesity and how to talk to patients about obesity. I have no relevant financial disclosure. I have no conflict of interest to disclose anything. My objective today is to define obesity and understand its classification using BMI and other measures, describe the global and national prevalence of obesity and highlight the alarming trends, discuss biological, behavior, and environmental factors that contribute to obesity, explain the health implication of obesity, including the role in chronic disease and reduced life expectancy, examine the economic and social burden of obesity on public health system, and the last thing, we'll talk about how to talk to patients about obesity and the 5 A's of obesity management. Obesity is one of the fastest growing health challenges worldwide, affecting more than 1 billion people. This includes children, adolescents, and adults. In the United States, over 40% of adults live with obesity, making it one of the most urgent public health crises of the 21st century. The WHO has identified obesity as a global epidemic, emphasizing its rapid escalation across all regions, income level, and at all age group. In the United States, about 42% of adults have obesity, a dramatic increase from 1970, where obesity rate was 15%, and that is according to the CDC in 2024. Let us start with the definition of obesity. Before I talk about the definition, AMA, American Medical Association, declared obesity as disease in 2013. So that's not too long ago, 12 years ago. And the OMA, Obesity Medicine Association, came up with this definition in 2017. Obesity is a chronic, relapsing, multifactorial neurobehavioral disease wherein an increase in body fat promotes adipose tissue dysfunction and abnormal physical forces, resulting in adverse metabolic, biomechanical, and psychosocial health consequences. We all agree it is chronic disease, relapsing, we can't cure it, multiple factors involved in obesity, and this results in body fat, promotes adipose tissue dysfunction, which is metabolic disorder, and abnormal physical forces, which is a mechanical effect of obesity, and this results in metabolic disorder like diabetes, biomechanical disorder, and psychosocial. It leads to anxiety, depression, and social isolation. Let's talk about the classification of obesity. The common classification is a BMI. We have overweight between 25 to 29.9, class 1 obesity, which is moderate obesity, BMI between 30 to 34.9, and class 2 obesity, severe obesity, 35 to 39.9, and class 3, which is extreme or morbid obesity, BMI more than 40. Just keep in mind that it is very important to know that BMI measurement is limited and does not reflect the cardiometabolic disorder, or it doesn't work for everyone. Like athletics and certain ethnic group, BMI doesn't differentiate between muscle or fat. So there is certain specific group, it doesn't work for them. Athletics, some ethnic groups, Asian, they have more visceral fat. Postmenopausal women has more visceral fat, so it doesn't reflect that. The other classification, waist circumference classification, I don't know who does that now, but that reflects the cardiometabolic disorder. In men, if the waist circumference more than 40 indicates high risk for cardiometabolic disease. In women, if it is more than 35, that reflects increased risk of cardiometabolic disease. I'm not sure if anyone uses the waist circumference now, but that's something we used to use in the past. For body fat percentage, which is very specific and that more accurate, in men, if it is more than 25%, that indicate obesity. In women, more than 32% indicate obesity. How we measure the fat percentage? By DEXA scan, which is a gold standard, or by in-body devices. And that is the BIA, bioelectric impedance analysis. And this is safe, use low electrical current, and it is helpful in monitoring and tracking patients with obesity and while they're losing weight. It does break down the fat percentage, the muscle mass, visceral fat, and body water. Let us talk about the alarming statistic of obesity. Overall, adult obesity is approximately about 43.1% from March 2023 to 2024. That was 3 in 4 adults consider overweight or have obesity. Severe obesity affects about 9.4%. There is higher obesity in adults between age 40 to 59. That is the peak age of obesity, between 40 to 59, compared with younger and older adults. Severe obesity remains higher in women of all groups. From 2000 to 2018, obesity rose from 20.5 to 42%, and severe obesity from 5% to 9.2%. The good news, according to the curve, they see slight decline in the curve this year. This is the first time obesity coming down a little bit. When I presented this last year, it was 43.3, and today it is 43.1. There is 0.2% reduction in obesity, and they think that related to the GLP-1 use in 2023 and 2024. Also, they don't see any, unfortunately, the severe obesity is still going up. They don't see any decline. They said this statistic is not accurate yet. They won't wait for more data from 2026 and 2027 to declare that it's coming down. But there is a slight reduction, which is very good news. The alarming statistic of obesity now is 2 in 5 US adults are suffering from obesity, with 1 in 10 experience severe obesity. In children, is 1 in 5 have obesity. The projection doesn't look good. 2035, they expect 50% of the global population could be affected by obesity. And the US rank on the top. In 2030, nearly 1 in 2 adults are expected to have obesity if the current trends continue going on. Let us talk about the obesity by states. Nothing changed from last year, from the last 3 years actually. We have still West Virginia holding the lead, followed by Mississippi and Arkansas. The obesity rate in this state more than 40%. The lowest rate we see it is still in Washington, D.C., Colorado, and Hawaii. The obesity rate between 23 to 25%. So far, 23 states have obesity rates more than 35, including Virginia. The South and Midwest are the highest. Obesity rate by ethnicity, obesity prevalence varies significantly across the different ethnic groups. In African American, 50%, Hispanic, 45.6%, non-Hispanic white, 41.4%. Asian generally have lower obesity rates, highlight the influence of genetic, cultural, and socioeconomic factor in obesity, and it's only about 16%. Socioeconomic status and obesity, the socioeconomic factors play a critical role in the prevalence of obesity. Education and household income level are closely linked to obesity. Adults with higher education tend to have lower obesity rate. In women, obesity prevalence decreased with higher income. For some reason, from 45, it came down to 30% when they have higher income. In men, they don't see that different. From 32%, it came down to 31%, only 1% different. It's not clear why, but obesity prevalence decreased with higher education. Among high school, without high school diplomas, 36.5%, college graduate, 27%. So higher income and higher education decrease obesity rate. I'm going to skip this. Just I want to point that obesity causes is multifactorial, multiple factor involved. Always not one factor. It could be genetic and it could be unhealthy diet, genetic and sedentary lifestyle. So always it overlap, and that's why obesity require multidisciplinary approach and long-term treatment. The biological contributor to obesity is not just about willpower. It is biologically driven and chronic relapsing disease influenced by genetic, hormones, brain regulation, and environmental interaction. About 40 to 70% BMI variation can be explained by genetics. The most common type of genetic obesity is the polygenic obesity, which is multiple genes contribute to obesity associated with appetite, regulation, fat distribution, and metabolism. There is other different type of genetic obesity, monogenetic, epigenetic, that is, you see it in pediatrics and in children. Hormones play a central role in development and regulation of obesity, influence appetite, satiety, metabolism, fat distribution, and energy expenditure. Let us talk about the hormone. The key hormone in obesity, number one, we have leptin, that produced by fat cells, and talk directly to hypothalamus, and usually when we have high fat mass, leptin level increase. Unfortunately, in obesity, we have something called leptin resistant. That means the tissue doesn't respond to leptin, so the leptin is not effective. We have ghrelin, that's other hormone produced by the stomach, and that we call it hunger hormone. This hormone increases when we are hungry, it peak up, and when we eat, immediately drop down. Ghrelin impaired in obesity, the secretion of ghrelin, it doesn't work properly, so there is impairment of ghrelin regulation. Insulin is the third hormone, and that produced by pancreas. The insulin promotes lipogenesis, and that's one of the problems. We have insulin resistance in obesity, and that increases the insulin level because the tissue is not responding to insulin, and one of the functions of the insulin is lipogenesis, which is fat storage. That's one of the issues in obesity. Sex hormone, we have in women estrogen, which is decline at menopause, and that shift of the fat from the peripheral area to visceral area or abdominal area when it declines. In men, we have low testosterone leads to central obesity. Cortisol, high cortisol always promote abdominal obesity or visceral obesity, and always is high in insomnia, in stress, and things like that. Incretin, we have GLP-1, GIP, and this is a gut hormone, and this is increased satiety, and also it helps improve insulin sensitivity. Adiponectin, and that is one of the proteins produced by the fat cells. It is helping in insulin sensitivity, but the level of this is very low in obesity. I'm going to skip this. That's just the environmental contributor. Food environment and physical inactivity, sleep deprivation. You just want to point about the sleep. Sleep is linked to obesity, and it has very strong relationship between sleep and obesity. When we have insomnia or interrupted sleep, always it alters leptin, ghrelin level, and increase hunger and craving. Also increase cortisol. But all these environmental factors involved in obesity, and it contribute to that. I want to talk about weight loss resistance. One of the problems we face in this field is always patients, when they start losing weight, they plateau, or when they lose the weight, they regain the weight back. So that will lead me to something called the set point theory. The set point theory suggests that the body weight is biologically regulated around preferred range. Like thermostat, always when you lose weight, your body wants to get you back to the same place. Set point theory helps to explain why weight loss is difficult to maintain, because the body actively resists the changes away from its defended range. The body defends the set point via neuroendocrine mechanism, hormonal change, and by reducing the metabolism. After weight loss, resting metabolic rate decreased significantly, making the weight regain likely to prevent further weight loss. When the body weight increases, the body responds by suppressing the appetite and increase energy expenditure to bring weight back to the set point. The opposite way, when we lose weight, the body increases the hunger and reduces metabolism and pushes the set point back. The set point can change through the life. When we are teen, we have different set point. When we are adult, when we age, different set point. There is different factor can change the set point. It could be genetic, environmental, lifestyle factor like overeating or sleep disruption. And this may cause the set point to shift always upward and always the set point go higher, making it sustain weight loss challenging. This highlights the importance of long-term lifestyle changes, medical treatment, pharmacological, and surgical intervention to overcome the body biological resistance. Always when patient asking why we need to be on medication long-term, that is a way also to explain that, because always the body resists for the weight loss and bring the weight back. So that's something why we need long-term medication or surgical intervention. Let us talk about the individual implication of obesity. The most common implication of obesity is that it predisposes someone to develop several chronic diseases such as cardiovascular disease, type 2 diabetes, elevated cholesterol, high blood pressure, stroke, osteoarthritis, fatty liver, gastroesophageal reflux disease, cancers, sleep apnea, infertility, depression, and social isolation. Mental health issues are very common. In individuals with obesity, obesity is considered a stigma and negatively affects the self-esteem. The repeated unsuccessful attempt of weight loss and maintenance can also negatively impact the mental health. It is important to address the patient overall health to help them to understand the implication of obesity on their health. Life expectancy. The relationship between severe obesity and decreased life expectancy remains the most concerning issue. The NIH study in 2014 found that severe obesity class 3 shortened life expectancy by 14 years when compared with the normal BMI. This reduction in life expectancy is comparable to the risk of smoking. The most common 3 causes of deaths in severe obesity are cardiovascular disease, type 2 diabetes, and cancers. And we'll talk about the cancer later on. Bariatric surgery is the most effective treatment for severe obesity, not only for weight loss, but also for extending life expectancy and preventing obesity-related complications. Individual implication of obesity, this actually summarized everything going on in obesity. But before we talk about what it does, let us know how it does it, first of all. In obesity, we have 2 mechanisms causing all of these diseases. We know that obesity causes about 200 diseases and 13 cancers. The mechanism is, in the obesity field, we call it sick fat disease and fat mass disease. What that means, just to make it simple, inflammation and mechanical effect of obesity. Obesity, it causes inflammation in the whole body, systemic, chronic, persistent. And the reason behind that, expansion of the fat cells signal the brain as a tissue injury, and that activates the immune system. Activation of the immune system results in systemic persistent inflammation in the body, accumulation of the macrophage and all the inflammatory marker in addition to the inflammatory cells. It is very chronic process, slow process, more weight gain, more expansion of the fat cells, and more activation of the immune system. The other mechanism is fat mass disease, which is basically mechanical effect of obesity. The weight on the knee causes osteoarthritis in the knee because of the pressure effect, or in the neck, obstructive sleep apnea. So this is basically the 2 mechanisms obesity causes all of this problem with, inflammation and mechanical effect. Actually, the obesity affects the body from the head to toe. We're starting with pseudotumor cerebri, stroke, which is direct inflammation to the cerebral artery. In the heart, there is 2 mechanisms, which direct and indirect. Directly, it can affect the coronary artery or cause diabetes, high cholesterol, high blood pressure, and that causes CAD. In the lung, we have obstructive sleep apnea, we have hypoventilation syndrome. Asthma in this patient gets worse also because of the inflammation. GI, we have the fatty liver, we have gallstones, we have hepatitis. We have pancreatitis, and this is just inflammation because of the mechanism I mentioned. GU, we have the urinary incontinence, we have PCOS, we have infertility, and irregular period. If we go to the knee, we have osteoarthritis, which there are two mechanisms in the knee. We have the mechanical effect and the inflammation effect. At the time, okay. So I'm going to skip this, okay. Let us talk about the cancer in obesity. 2 minutes? So move faster. So I have the causes of the cancer in obesity. We have chronic inflammation. We have hormonal disruption. The fat cells produce estrogen, insulin, and insulin growth factor, and this promote growth of the cells. And the immune system is not working effectively. That's another thing. The implication on public health as obesity continues to grow, we know that we know that this not only affects the mental health and the individual, but also affects the public health system. And the cost estimated about 73 billion a year for the obesity. And the obesity contributes significantly to direct medical cost and indirect cost. And the direct cost is treatment, medication, hospitalization, and the indirect cost is loss of productivity, disability, and early mortality. I'm going to skip. Let us talk about how to talk to patients about obesity. Obesity is a sensitive topic, okay? Patient experience stigma, shame, blame related to their weight. If the conversation are not approached with empathy, patient may feel judged, shut down, and avoid follow-up and care. When treating the patient, you must build trust and rapport with the patient. Use respectful patient-first language. Instead of saying obese patient, you will say person living with obesity or patient suffering from obesity. When there is trust, always this increased likelihood the patient will share openly about their challenge, habits, and goals. This also improves patient engagement. When patients feel supported rather than blamed, they are more willing to engage in the lifestyle changes, medical therapy, and even consider surgical option. We use 5 A's of obesity. That is the way how to approach a patient, which are ask, assess, advise, agree, and assist. Always ask the patient for permission when you want to talk about obesity. If the patient accepts it, you can move forward. If they don't, you have to respect that. We know that it is stigma, maybe people, they don't want to talk about it, so that's something. Assess the patient in the next one. Always try to evaluate the patient, find out where they are, check their BMI, which stage they are. If there is anything need to be checked, look for medical causes, look for thyroid, PCOS, if it is diet, exercise, whatever it is, so try to point what is the problem. Advise the patient, share evidence-based information always with the patient. Don't focus on the just numbers only, but on the scale, but focus on the benefit of the obesity, the weight loss, which is about 5 to 10%. Weight loss can improve the blood pressure, or improve diabetes, and so on. Agree with the patient for realistic goal, and consider that the patient preference, whatever he wants to start with, if they want to do lifestyle therapy, which is just changing their diet, if they want to start medication, if they agree for surgical option. So agree with the patient for what they want to do. Assist the patient, be proactive always, refer the patient and give them the support they need. If they need to see the dietitian, or if they want to start medication, you can do that. Or if you want to refer them to somewhere else or refer them to surgical option, that will be an option. So try to be proactive and helpful to the patient so they can get the care they need and the support they need. The last thing, I will do the summary. Obesity is a chronic relapsing multifactorial disease caused by genetic, hormonal regulation, environmental exposure, and biological weight defense mechanism. This is why obesity is complex disease rather than simple matter of willpower. The global and national burden rising, 1 billion of people worldwide with obesity, including 42% of US adults, and the projected is about 50% in 2030. Obesity significantly increases the risk risk of multiple chronic disease, including cardiovascular disease, type 2 diabetes, stroke, sleep apnea, fatty liver, osteoarthritis, and certain type of cancer. Obesity is not just about personal health, it is national economic crisis and national security concern. Preventive strategy such as nutrition, physical activity, and early intervention by medication or surgical are not only health improving, but are also cost saving investment for government and employers. The 5 A's of obesity focus on not telling the patient to lose weight, but also partnering with the patient in respectful, structured, and supportive way. Treat the person, not the number. Obesity management succeeds when approached with empathy, continuity, and collaboration. That's it. Thank you.
I can see here all your references too. Thank you so much, Dr. Osman. Okay, so I'm Lynn Montague-DiDio. I'm the bariatric coordinator here and clinical nurse specialist by background. So today I'm going to be covering a little bit more in depth a bit of what Dr. Osman touched on about some of the conversations and the sensitivity. But I do want to thank you again, all of you, for being here this morning. It's really nice to see so many new faces and also returning faces each year. So this topic is something I'm pretty passionate about, since even one negative interaction can have quite an impact on someone who's living with obesity, and whether and a positive interaction also has quite a huge impact too. So I have no actual or no disclosures at all. While you may not have heard of the term societal weight stigma before, you've undoubtedly seen examples of weight stigma throughout your life. Societal weight stigma includes stereotyping and devaluing people with obesity because of their weight and their body size. As Dr. Osman just discussed, obesity has a lot of contributing factors. I mean, really very extensive. I thank you for covering all of that. It really is a lot that feeds into the causes of obesity. So weight-based discrimination is driven partly by the belief that a person could lose all of their excess weight if they just tried hard enough. And weight stigma is divided into two categories. You have this explicit or often an intentionally or an outward negative treatment or attitudes towards individuals with higher weights. But there's also this implicit, the more subtle negative attitudes or behaviors directed at those people. And someone with implicit bias may be completely unaware that they're acting in a discriminatory manner or that they hold on to these feelings. And just as a side note, there is some good news here, which I put a little asterisk at the bottom of this slide. There was a 2022 study by Charlesworth and Banaji where they pooled data from over 7.1 million implicit and explicit attitude tests in the U.S., and they found that reports of explicit bias in the U.S. Had decreased over 30% in the prior 15 years. So I think people are recognizing that this is an issue, and I'm definitely, just across social media and things like that, I'm seeing a lot more, body positive and weight inclusive messaging. So certainly I think that's a trend that we'll continue to pick on. And as the research on weight stigma is growing, so are the findings on its probably most significant impact, which is internalized weight bias. Internalized weight bias is where stigmatizing experiences, take root in the person who's living through those experiences, and they internalize them as a negative self-judgment. And I'll just briefly pause to ask, how many of you have ever been caught off guard by a child's question or comment about weight? Anybody? I'm like, I have kids and the things they say are wild sometimes. Children are absorbing information from everywhere, and they're picking up on societal cues about weight-based discrimination. I was absolutely stunned when I first learned, this is an older study, so it was in 1998, children were asked to identify the mean character in a story, and children as young as 3 years old overwhelmingly pointed to the character with the higher weight as the mean person, and even more selected that character at 4 and 5 years old. But messaging about weights carried on throughout the schooling years. Hopefully you can see that okay. Yeah. And it may come from some pretty unexpected places, like this quote from an educator who said even the school desks are sending a message to children in bigger bodies that they're not valued. And I will apologize for the grainy image here, but I really enjoy the content by a dietitian, Diana Rice, who runs a social media account called Anti-Diet Kids. And you can see that kids are learning weight bias from even well-meaning school health programs and adults. As an example, I've been a troop leader for years. I can't even begin to count the number of times that people stop at cookie booths and tell kindergartners and teenagers alike that they can't buy cookies because they're bad, or the cookies will go straight to their waistline. And even if they're not telling the child directly, don't eat cookies, a 5-year-old will hear that, and then as soon as that adult walks away, will turn around and ask me, what's a calorie? I mean, the things that they're picking up are they're alarming. So, or a 13-year-old hears an adult say cookies are bad, and I'm almost an adult, so cookies are a bad food, and that does over time internalize and become like that internal dialogue that they're hearing. And children who are internalizing weight bias become teenagers and adults with much bigger issues, as you can see here, and I'll share a little bit again in just a few slides. So obviously this isn't a United States specific issue. It doesn't stop when people reach adulthood. I had the privilege of hearing Dr. Rebecca Poole speak on her research about weight stigma this summer at a national conference, and it was just astonishing. This particular study, it wasn't specific to metabolic and bariatric surgery. It was a commercial weight loss program. Is one that she discussed, so I'll just give you a quick summary. So there were almost 14,000 adults enrolled in a commercial weight loss program across 7 countries, which you can see across the top, and they were asked about, they were asked about their sources of weight stigma, and I thought the numbers were pretty shocking. Going to a health care provider should be a safe space to talk about your health, and not a place where almost 70% of the participants are reporting as a source of weight stigma. And as a side note, the very first reference I have on my reference page is that video, that lecture that was linked, if you want to watch a little bit more of it. These are some sources that contribute to those high reports of weight stigma in healthcare. It's not just words or behavior from the providers, it's the physical space. It's like those kids that are not fitting into their desks all over again. It's feeling that your provider or their providers are judging and not listening to their symptoms, or it's even past negative experiences within the healthcare system that maybe you've had absolutely nothing to do with, but that those experiences are making people with obesity think that every time they come in to see a health provider, it's going to be just like that terrible experience. And if all of that information doesn't move you, this is really why it matters, and hopefully you can see it. It's a lot of information. Weight stigma is a psychological and a physiological stressor. People who experience it, especially repeatedly, are prone to develop maladaptive eating behaviors, poor exercise behaviors, because not surprisingly, the gym is also a source of weight stigma. The stress of weight stigma increases cortisol levels, C-reactive protein, A1C, and blood pressure. And if you can imagine, if people are feeling shame or frustration with healthcare services, they're less likely to follow the advice of their providers, like Dr. Osmond was saying, or they may not even come to the appointment at all. And the long-term psychological effects are just like what we saw on the slide I shared about the children. People who experience weight stigma are even more likely to suffer from depression, substance abuse, and suicidality. And on top of that, obviously very important for this session as well, internalized weight bias impacts weight maintenance. Another study with over 18,000 participants, it controlled for multiple covariates, like you can see here, and found that people with higher internalized weight bias had poorer weight management behaviors, were less likely to achieve significant weight loss, and had higher odds of weight gain. So that's a pretty big deal. And all this to say, weight bias in healthcare is a significant barrier to effective obesity management, and it's been highlighted as a public health priority. Just as a side note, the Obesity Association encourages healthcare systems to meet all of these 3 criteria here, but these are also standards of care for all centers, just like ours, that are accredited for metabolic and bariatric surgery by MBSAQIP. So what can you do? That's a lot of stuff. Very simple things, just 3 things that will hopefully help you create a more inclusive safe space for the people around you. This isn't an exhaustive list, but quick assessments like these can help generate discussion about beliefs or stereotypes that you hold, which you may not even be aware of, that could reinforce this bias towards patients. Like Dr. Osman had mentioned, language is a huge, important factor in this. Person-first language, we say a person with obesity, not an obese person. Instead of saying, why aren't you exercising more, which would make most people defensive, ask what gets in the way of you when you want to exercise. And just think about, if someone were to tell a patient, I'm referring you for weight loss surgery as a last resort after you failed these other treatment options, or if a patient read that in a note, it doesn't instill a lot of hope. It feels last resort. But a more accurate and more encouraging statement would be, I'm referring you to a specialist for metabolic and bariatric surgery. It's one of many treatments for obesity, and 80% of people lose 50% or more of their excess weight in that first year, and then talk about and outline the many metabolic benefits of having those procedures. In terms of creating a weight-inclusive space, I think our hospital does a beautiful job of this, and everyone is really good about picking up on when things need to be updated or more inclusive, which I love. Thank you. You make my job easy. But really, preparation is key. In my role, I know, if someone I know is coming in for labor induction, their weight is higher than what our standard equipment can safely accommodate, I can work to get all the supplies and equipment ready and have a safe delivery without the patient ever knowing that the stuff isn't usually in that room. But if you're in an area where you don't know who's coming in, preparation might mean having a designated exam room, designated patient rooms, or having equipment and supplies that are on hand that are accommodating for higher weight capacities. A variety of blood pressure cuffs and gown sizes ready to go, so that way you're not trying something and then having that not fit and then having to run out of the room to go get something else. And part of obesity sensitivity really is having appropriate supplies and equipment so that you're able to provide safe care and keep your patients comfortable. So my summary, weight-based discrimination can lead to internalized weight bias for people with obesity, resulting in significant psychological and physiological consequences. Healthcare workers can address this public health priority by creating weight-inclusive spaces with their language, actions, and environment. And I have a very long list of references as well. And I will go ahead and turn it over to Dr. Arshad Ali.
Morning, everyone. Thank you again so much for joining us today. So my name is Arshad Ali. I'm one of the obesity medicine docs here. So we're going to talk about medical management. I have also no disclosures. So the goals for the presentation, just to kind of go through, review how obesity is a chronic disease. We'll talk about the interventions for obesity management, specifically pharmacologic treatment, and then go through the kind of pros and cons of the different therapies. So, question, which everyone should be able to answer now after Dr. Osman's presentation. Is obesity a chronic disease? Yes, it definitely is. So there's kind of two buckets we want to think about when we're talking about what's going on with obesity. So the first thing, which is I think what most people think about with weight gain, is this idea of energy balance. So calories in, calories out. And that does partially, like at the baseline, explain why someone is gaining weight. If there are excess calories coming to the body that the body's not using, the body will store them. But in obesity medicine, sometimes we use this kind of like restaurant analogy to say if there's a bunch of people in a restaurant, because a bunch of people walk through the door, that doesn't tell you why there's a bunch of people in the restaurant, right? So there's a lot of like is the food good? Is the food bad? Is the environment good? Is the environment bad? So in a similar way, what is going on with the regulation of that intake or lack of intake. And that is all happening in the brain, which, again, Dr. Osman touched on how that works. So there's this kind of nice phrase sometimes we use in obesity medicine that it's not simply physics, it's physiology. Because your body is not a machine. There's a lot of, as Lynn mentioned, psychosocial factors. All these things are going into why this is happening. So if we look at this diagram here, I always like showing this. So this is kind of like a map of all the metabolic processes in the human body. Just to illustrate, the body's not a simple machine, right? There's a lot going on underneath. And if our body were a machine, how it would use calories would be, this is a machine that measures calories. It's called a bomb calorimeter. So basically what you do, if you want to measure how much, let's say, energy you get out of a piece of bread, you stick it in this machine, it causes an explosion, essentially, and the machine measures the energy given off by that explosion, and then we know, okay, this piece of bread has 25 calories, let's say. But when you eat a piece of bread, this is what's happening. So there's a lot more going on underneath. And all of these processes lead to a regulation, which, again, was explained before, of this set point. So basically, as you gain weight or lose weight, but more specifically as you gain weight, your brain resets the point where it wants to keep your weight at, or the fat mass at. And we call that the set point. So this is all happening deep inside of the brain, in the hypothalamus. So this is a diagram of the hypothalamus. So can you see my cursor? Can you see the cursor? We have this. Okay, it's not working. That's okay. So basically what this is showing is how all these different hormones are interacting with the different parts of the hypothalamus. And a kind of simple way to understand this is that there are basically two major pathways that the hypothalamus is turning up and down. So I explain this to patients as, imagine that these are like little dials that your brain is turning up and down. So one pathway controls the level of hunger. And if you can see the little green, the NPY, that is the hunger pathway. It's called the neuropeptide Y pathway. And so when that is stimulated, you feel hungry. The other one, if you see the red one, the POMC, the POMC, that's the propiomelanocortin receptor pathway, and that controls fullness, or sometimes also cravings. So when that is turned up, you feel satiated. So we think about hunger and satiety. So when you eat and drink, all the food is essentially going into your intestine, right? And the intestine can detect whatever you put in there. And then as a result, a bunch of these hormones that again, Dr. Osman explained all the different hormones, they come out and they tell the brain to do different things. So if your body detects you got enough calories or nutrients, the brain will turn up that neuropeptide Y pathway and you'll feel, turn down the neuropeptide Y pathway and you won't feel hungry, and it will turn up the POMC pathway and you'll feel full. On the other hand, if you don't eat enough, because you're coming to a doctor and they're telling you, okay, eat less, move more, exercise, do all these things, what's going to happen is your gut is going to tell the brain, we don't have enough energy coming in. There's not enough gas in the tank. So your brain's going to do the opposite. There's going to be different hormones like ghrelin that come out that turn up that neuropeptide Y pathway, so now you feel more hungry, and inhibit the POMC pathway, so now you feel less full, or you want to eat more, you have more capacity to eat. So that's kind of, in a nutshell, how your brain regulates this. I'm going to skip these slides because Dr. Osman did a good job of talking about how we measure obesity. So these are kind of stages of obesity. And this is just to reemphasize, and again, this was spoken about before, how obesity is a full body disease. It's a multi-organ disease. So again, there's these two camps, or these two kind of groups we put the types of disease that obesity can lead to in. The sick fat disease, which is the inflammatory processes that happen when there's too much adipose tissue, especially in the visceral cavity. And then the fat mass disease, which is the effect of the excess weight on the musculoskeletal system and on the cardiovascular system. So how do we treat this, right? So if we think about that first slide, we have to reverse that calorie balance, right? So we have to put the patient in a calorie deficit But that can be tricky because in creating calorie deficit, what we don't want to do is create a nutritional deficit. What I mean by that is even when you're trying to lose weight, you still need to eat, right? If we just needed to give you calories, we could hook you up to an IV and infuse sugar water into your veins and give you 1,500 calories a day. And theoretically, you should lose weight and be okay. But we know if we did that, you would get very sick, and after a couple weeks, you probably wouldn't be around anymore because you're not getting any nutrients. So the issue is if we over-restrict just calories and we're not giving you enough protein or fat or carbohydrate or nutrients and minerals in your diet, you're not just going to lose body fat, you will lose muscle, bone, skin, other tissue. And this kind of goes back into what Dr. Osman was talking about, the BMI, is that the BMI, it tells you how much mass there is, how much weight there is on the body, but it's not telling you the breakdown of muscle, bone, skin, etc. So you could lose 10 pounds, but if half the weight you lost was muscle, bone, and skin, that's not necessarily a good thing. So we kind of have to make sure you're eating the right type of foods, which I think we're going to have some lectures on that later on, while at the same time we're kind of helping you create this calorie deficit and helping your brain deal with the consequence of the calorie deficit, which we mentioned was increased hunger, decreased satiety. So there's a lot of things we have to do to make this successful. So when we talk about obesity treatment, I kind of think about it as like 3 layers of therapy. So the base layer is dietary and lifestyle change. If we don't do that, then we're not going to be successful at all. But we can use things to help you to do those baseline changes. The focus of this talk is going to be the pharmacotherapy, the medications, but this is also where surgery and endoscopic intervention all come into play. So very specifically on the medications, how do they work? So if we go back to the brain, right? All of these medications primarily work in your brain. But before I say that, we'll just talk about when would they be indicated. Because this is a very common question, especially with the new GLP-1 agents. Everyone wants to be on them, but there are appropriate use cases and inappropriate use cases. So really, these should be used to treat patients who have obesity, which generally we're defining based on BMI, despite the limitations, just because it's an easy metric we can use, and it's relatively accurate. So if someone's BMI is over 30, or their BMI is over 27, and they have a weight-related comorbidity, such as high blood pressure, diabetes, high cholesterol, something like that, then these drugs can often be indicated to help with that. Often also we use it for weight regain after bariatric surgery, especially if they're in these BMI categories still. So essentially what the drugs do is they lower that set point. And there's a bunch of them that I listed here, and we'll go through them in a little more detail. So the first group of drugs, these are much older drugs. They've been around since the 1960s. They're called sympathomimetics. The most commonly used version of this drug is something called phentermine. So essentially what they do is they inhibit dopamine and serotonin reuptake in the brain, and primarily they work on that neuropeptide Y pathway. Oh, I have the wrong slide here, sorry. I'll work on the POTSI. So if you, I'm just going to scroll ahead. I think I reversed them. So they basically inhibit this pathway. So now you feel essentially less hungry when you're on these drugs. So there's pros and cons to using all drugs, right? The adverse effect of these drugs is that they are mild stimulants. So they can increase the heart rate, increase the blood pressure, they can cause palpitations, they can increase anxiety sometimes, they can cause dry mouth. Technically, according to the FDA, we should only be using these as short-term use therapies. They're only officially approved to be used for 3 months at a time. However, most obesity medicine physicians and endocrinologists will use these as long-term therapy off-label. And we do have a lot of data that suggests they're actually very safe to use for years. I have a patient who's been on for decades. But it just needs to be a conversation you have with the patient if you're going to use it beyond 3 months, that they know that this is an off-label use of the medicine. Sometimes to enhance the effect of certain sympathomimetics, you can add a drug called topiramate, which is a GABA receptor modulator. and that sort of augments the ability of the phentermine to suppress that pathway in the brain. Interestingly, the combo drug is approved for long-term use. I'm not sure why that is, but it may just be because it's a newer formulation. So that's another thing to consider. Both of these categories, the sympathomimetics on their own and mixed with topiramate, generally result in around 10% loss of your starting body weight. In really rare cases, we can get up to 15 or 20%. The average is more like 10%. So the next category is the one that everyone is talking about these days. These are GLP-1 agonists. So these are very smart drugs, much newer drugs. They've been around for about 5 years or so. And they essentially mimic one of those intestinal hormones, it's called GLP-1, that tells the brain to essentially turn that satiety signal up. That POMC pathway gets turned up when you take one of these drugs. There are gut hormones, so they affect also the gut motility. So a way I describe it to patients is when you're taking this drug, you will feel fuller faster, and because it's slowing the gut motility down, you stay fuller longer. So it doesn't directly affect that hunger pathway, but in an indirect way, because you're so full for so long, you end up not feeling hungry. But because they affect the gut motility, they can have adverse effects. Mostly they're gastrointestinal, gastroparesis, nausea, vomiting, diarrhea. There are some more serious things like pancreatitis and cholecystitis that can be associated with this drug. There's a rare form of thyroid cancer, medullary carcinoma of the thyroid, that can also be associated with the category of drug. But generally, they're very safe. They're generally very well tolerated. Depending on the drug we use, we can get somewhere between 10 to 20% loss of the starting body weight with these drugs. So they're very effective, and they are approved for long-term therapy. The third category of medicine is a drug called Contrave. So this is a mix of two drugs that you may be familiar with. The first one is something called bupropion, which we use to treat anxiety and depression. And it's mixed with another drug called naltrexone. I apologize, there's another typo on the slide here. It's not naloxone, it's naltrexone. They are closely related. And basically, this works on a different part of the brain. And this just goes into more of how complicated this gets. But essentially, there's a part of the brain, it's more in the prefrontal cortex, that affects desire and cravings and sort of that psychological attachment to eating. And this modulates that in a way where it decreases the dopamine and norepinephrine uptake, which leads to decreased appetite and very specifically decreased cravings. So if a patient is having a lot of issues with cravings, this can be a really helpful drug for that. There are some older drugs, which I personally don't use. I don't know if Dr. Osman uses these, but there's another drug called orlistat, which has kind of fallen out of favor. It's a pancreatic lipase inhibitor. So essentially, it blocks fat absorption in the gut. The downside of that is the fat has to come out somewhere. So the side effects are not great. You can get this oily rectal discharge, flatulence, diarrhea, bloating. So patients generally don't like how they feel on this drug. It's also not that effective compared to the other therapies we have. So I generally don't use this drug very often. This is not really a drug, but I just wanted to mention, sometimes patients ask about this. There are these oral hydrogels that are available. A common brand is something called Plenity. So basically, these are capsules you take about 30 minutes before you want to eat something, and they expand in the stomach, and they increase the stretch of the stomach, which creates a neural signal to the brain to increase satiety. So then you end up not wanting to eat as much, essentially. They are kind of cumbersome to use. You have to take it before every single meal. They can have some GI distress, like nausea, vomiting, diarrhea, depending on how your gut takes to them. They also tend to not be that effective. They're less effective even than plain phentermine. So I personally don't use these very often. But it's another resource that's, we could say, medicine adjacent. It's technically, I think, considered a medical device. And I didn't have a slide about this, but I just wanted to mention that this is a very active area of research. So there's a lot of upcoming therapies that will be here in the hope for the next 2 to 5 years. There are oral versions of these GLP-1 agents. So I don't think I mentioned this, but the things like Wegovy and Ozempic, these GLP-1 agonists, they're all subcutaneous injections right now, but they are developing oral versions of these, which hopefully in the next year or so will be out. There are stronger versions of these also coming out that result in even more weight loss. And there are other non-GLP-1 drugs. There's a category called activin receptor agonists that they basically, very interesting. They're still in phase 2 trials, but they lower the visceral adiposity and increase the muscle mass. So there's still research to be done on them, but there's a lot of upcoming therapies. So this is a very exciting field, exciting time. And that's all I have for you today.
Thanks, Lynn. Awesome. So switching gears a little bit and talking about now surgical therapies for obesity. I'm Jay Salame, bariatric surgeon here at VHC, and I have nothing to disclose. So when we talk about bariatric surgery, who do we consider it for? So the indications have actually changed recently. Last year, there was an update to the indications for bariatric surgery. And now we would consider bariatric surgery for patients with a BMI between 30 and 35 if they have diabetes or another obesity-related comorbidity. And we would consider it for anybody whose BMI is over 35, regardless of having any medical issues. As Dr. Usman mentioned earlier, there are certain racial changes or influence with weight, and Asian populations are more susceptible to obesity and more visceral fat. So with the Asian population, we would even consider it for even a lower BMI. And these are so the latest guidelines by ASMBS and IFSO, which is the International Federation for Obesity. And if we look at bariatric surgical numbers in the US over time, you get a sense of what we're doing in the US in the past few years. The last data available is from 2023. So in the last couple of years, maybe some slight change. But the two most common surgeries we do are still the sleeve gastrectomy and the gastric bypass. So you can see in 2023, almost 160,000 sleeves and about 63,000 bypass. So very common procedures for sure. And then the surgery that's really getting a lot of traction lately and expanding a lot faster now is something called SADI or SADI-S, which is a modified duodenal switch, and we'll talk about that a little bit today. And this is, I think, the numbers with that surgery. If we look at 2024, 2025, they're probably going to be almost double of what you see here on the slide. And we do a lot of revision still. You heard quite a bit about obesity being a chronic illness, chronic disease, and certainly revision surgery is also common. So gastric bypass is one of probably the oldest surgeries available, been around for a long time, very effective. And that surgery consists of making a small stomach pouch. So the stomach is transected, creating a small little stomach that's disconnected from the rest of the stomach. So when patients are eating, they're only filling that small little pouch, which is maybe 10% of the size of the stomach. And then the small bowel is connected directly to that pouch. So this is that surgery is going to allow for eating less, but also absorbing slightly less of the food patients eat. You can see here in the video again. This is robotic minimally invasive surgery, and you can see the small bowel sort of getting connected to the pouch, and then the intestines connected back together. The other surgery that is very common is the sleeve gastrectomy. And the sleeve gastrectomy, again, the most common surgery we do in the US and actually worldwide. That surgery is a bit simpler to understand. It's basically removing 70% of the stomach and making the stomach into a sleeve, a narrow tube. And you'll see here in the video how we sort of mobilize the stomach, free up that greater curvature of the stomach, then dividing the stomach and creating that sleeve. As I liked what Dr. Ali said about it's not physics, it's physiology, right? That's pretty cool. I'm going to steal that from you. But this is the same with surgery, actually, because although we are creating mechanical changes, really the effect is very much metabolic and hormonal. So with the sleeve gastrectomy, removing 70% of the stomach is actually reducing ghrelin, which is the hunger hormone made up in the stomach. And that's going to have a huge impact on hunger. And of course, you can have early satiety. And then finally, the SADS, which is, as I said, one of the rapidly growing areas in surgery. It's basically creating a sleeve gastrectomy, like I showed you earlier, but then disconnecting the sleeve from the small intestine and then essentially rerouting the small intestine so the food that the patient eats doesn't go through the entire intestine. It just bypasses a lot of the intestine. So we basically do the sleeve, which is what you're going to see here in the video, dividing the stomach and make it into a small tube. Here we're using multiple fires of the stapler to create that small sleeve. But then the sleeve gets disconnected from the duodenum. And this is the sleeve right here. And the stomach is completely removed. So we have that component of the sleeve. Here we're dividing the duodenum, separating it, essentially separating the sleeve and the proximal duodenum from the rest of the small intestine. Then what we do is we go to the terminal ileum, to the cecum, and basically measure 300 centimeters of small bowel and connect that part to the duodenum. So we're connecting the duodenum to the ileum. So essentially the food that the patient is eating roughly is bypassing half of the intestine. So basically they're eating less and absorbing less. Again, a lot of metabolic effect from this, not just eating less and absorbing less, but also a lot of hormonal changes. With the gastric bypass, with this, we see a big change in an increase in GLP-1, as I heard with medicine. A lot of the research on medicine really started with the surgical therapies. We kind of do get those same long-lasting effects on hormonal changes in the gut hormones, which ultimately impact weight loss. So what are the outcomes with the surgeries? If you look at the sleeve gastrectomy in terms of total body weight, we have a lot of data on sleeve long-term. These are 10-year data on the sleeve, 24 to 25% weight loss in general. If you look at the gastric bypass, these are 20-year data of total weight loss of 24, 28% at 20 years. So very good, long, durable weight loss. With the SADS, we don't have that long of a data. At 5 years, we have about a 33 to 34% weight loss, total body weight loss, which is pretty impressive. The diabetes remission is, again, a big part of why we do surgery, to have that, again, the metabolic effect, and especially on diabetes. With the sleeve, it's not that bad. It's 45, maybe 50% resolution of diabetes. It's better with the bypass, 58 to up to 80% in some studies. And with the SADS, very, very strong effect on diabetes, 80, 81% resolution of diabetes altogether, which is, again, very impressive. When we look at complications, of course, with any surgery, there's always risks involved. I'm talking here about more long-term risks. What do we tell these patients? What are the issues to look for over time? The main complication, the main risk with the sleeve is the issue of reflux or GERD. That's probably the biggest side effect with the sleeve. Maybe 20, 25, 30% of patients may have some degree of GERD, and so we certainly counsel patients on that. With the gastric bypass, I would say the biggest long-term risk is the risk of ulcers, because you're connecting the stomach straight to the small bowel, and you're bypassing the buffer area of the duodenum where that neutralizes the acid. Patients are more prone to get what we call marginal ulcers. And so patients who have gastric bypass should avoid anything that can cause ulcers, like NSAIDs, aspirin, steroids. So if you have a patient who's had a bypass before, certainly try to avoid those drugs. With the SADI, the main issue is the risk of malabsorption, of course, because we're creating less absorption. And diarrhea, patients will experience a bit more frequent bowel movements with that surgery. So if somebody has normally 1 or 2 bowel movements a day, they can expect to have maybe 2, maybe 3 a day. So a bit more increase with bowel function. There's also a nutritional risk with any of these surgeries. We do monitor these patients long term. They work with our team, with our dietitians. We do regular blood work. With the sleeve, mostly B12 is what we watch for, because we take out the stomach's part of the stomach, so we remove the intrinsic factor that allows absorption of B12. So we do monitor that. We supplement that. With the bypass, we see deficiencies in B12, but mostly in iron, calcium, vitamin D. So we got to monitor this and supplement patients. With the SADI, we do have to watch for the fat-soluble vitamins, A, D, E, and K. We got to monitor those because they do get potential risk of deficiencies. And when we look at revisions, I see another thing. What are the chances of needing another surgery in the future? It's not insignificant. There is always that possibility with the sleeve because of the risk of reflux. Some patients may need surgery for that. And if they have weight regain, they can also need a revision for that. Up to 19 to 20% of patients might need a revision for one of these two reasons. The sleeve is often done sometimes as a two-stage procedure for somebody with a very high BMI. So we are doing a sleeve first. Somebody's BMI, let's say, is 60 or higher. They lose weight, and then we can come back later and do the SADI. So sometimes that revision, that second surgery, is almost planned. With the bypass, we do see long-term risks of reoperation from internal hernias because of the rerunning of the intestines. That does introduce a risk of intestines, herniating behind another loop of intestine. In the earlier studies, that was more common. Now we see it a lot less because of some surgical changes we've done with the technique to reduce that risk. With this ADS, surprisingly very low risk of reoperation in the future, maybe 5-10%. So it actually does really well in the long term when it comes to revision. If we had to compare CADS versus bypass, what are the studies? What do we have? We have actually some really good, strong data on that. Looking at comparing the two, this is a prospective randomized trial that included over 300 patients and randomized them for both these procedures. 20% of the patients in that study had a previous sleeve, so they had sleeve to bypass or sleeve to SADI, and we compared the two groups. The results at 2 years were pretty impressive and significantly better. Significantly more weight loss with the SADI as compared to the gastric bypass, 76% at 2 years versus 68%. And the serious adverse events were the same. So no increase in complications, but increased weight loss between the two interventions. And if you look at meta-analysis of all the studies comparing these two, we have 8 studies, over 4,000 patients. Same thing, the SADI does show a higher weight loss at mean follow-up of 4.6 years. So it does better than the bypass. It has a higher diabetes remission at the mean follow-up of almost 4 years. And then the risk of short-term complications is similar, and the risk of long-term complications is similar. So I think that's kind of why the CADS is becoming very attractive as an option for a lot of patients. We have more patients coming asking for that procedure, and so I think it really has a lot of promise for very good outcomes. How do we decide? Well, we look at multiple things. It's not just one thing. We look at BMI. Of course, we talked about the indications for surgery, but essentially patients who have a higher BMI, we would favor the CADS. And if the patient is not really interested or doesn't want to go that far, we would consider the sleeve for those patients, with the idea that we could later on do a CADS if they don't lose as much weight with the sleeve as we would want. We look at diabetes. If somebody's diabetic, especially if they have been diabetic for a long time, if they have poorly controlled diabetes, or if they're on insulin, those patients will certainly do better with the bypass or with the CADS, so we would probably favor that. Do they have GERD? If somebody has GERD to start with, we're probably not going to do the sleeve gastrectomy. Those patients will benefit more from a gastric bypass. The CADS has a sleeve component to it, so we would also avoid that. So somebody with reflux, certainly if they have Barrett's, we would consider the bypass over anything else. How compliant is the patient? Is the patient going to follow up? When they went through the process with us, did they miss all their appointments? How did they do? What's their history? If somebody's not going to be very compliant, we're not going to do a very, very hypoabsorptive procedure, because we know that may not come back and follow up, so we'll favor a sleeve. When it comes to revision surgery, I mean, of course, if they had a sleeve before, we're considering the bypass or the SADI in those patients. And ultimately, it's sort of a shared decision, right? We're going to discuss all this with the patient. We're going to see what they're hoping to achieve, how much weight loss they're hoping for, what's their risk tolerance, et cetera, and we're going to make a decision together. So in conclusion, the sleeve certainly remains the most common, but also the safest metabolic surgical option. And the main thing to watch for is an increased risk of GERD. The bypass is certainly very durable. but does have more long-term complications or risks. The CDS does offer superior weight loss and diabetes remission with a very good safety profile comparable to gastric bypass, especially when the intestine that we bypass is a bit less. And then, of course, lifelong monitoring, supplementation, and multidisciplinary approach to taking care of these patients is certainly critical. Thank you.
Good morning, everybody. My name is Saad Haq. I'm a gastroenterologist here. I've been invited back by Dr. Salome. Thank you very much. This topic is to talk about endoscopy in bariatrics. And this is a huge topic. I've been asked to fit this into 15 minutes, so I'm going to do my best. So bear with me. No financial disclosures. So as I was thinking about this presentation, I was thinking, when do we do endoscopy? Around the time of bariatric surgery, before? Is this potentially a primary procedure in itself? So forth. So I came up with these 3 time points: pre-bariatric surgery, around the time of bariatric surgery, or the endoscopy acting as the primary procedure, and then post-bariatric surgery. And there are multiple reasons why we do this, which I will go over very fast, but certainly I will go over. So when do we do an endoscopy before the procedure? We do this because, as Dr. Salomon was talking about, the reflux issues associated with certain types of surgical procedures. You want to know about that before. You would assume that patients know they have reflux, but they don't. About 15 to 20% of patients have what is called silent reflux, where when you look inside the esophagus, it looks like that. It looks like raw steak. And when you ask them, they say, oh, no, I have no symptoms. But this qualifies as gastroesophageal reflux disease, and this affects the type of procedure that they should have, etc. We find ulcers. That's what an ulcer looks like in the stomach. That's very important that it be treated before surgery. We find Barrett's esophagus, which is a precancerous condition of the esophagus with scarring. And sometimes we find submucosal lesions, which could potentially be GIST lesions, gastrointestinal stromal tumors, that need to be dealt with before surgery. So this has to be all taken into account before surgery. Now, how often is this happening? Well, I was actually surprised when I came across this paper when I was preparing for this. In about 20% of patients, and this was the largest meta-analysis done a couple of years ago, about 24,000 patients, there is some sort of change to the surgical planning because of the initial endoscopy. Now, this could be something as simple as treating the patient with PPIs for a couple of months, to something as significant as changing the surgery to something, as Dr. Salome was alluding to, going from potentially a sleeve to a SADI or a Roux-en-Y gastric bypass. The other aspect of this is that, as you heard, sleeve can lead to reflux, and that, by extrapolation, can lead to Barrett's. In about 6% of patients, followed for a few years, usually 3 years after a sleeve, patients are known to have Barrett's esophagus. So if that is the case, you want to know well before any kind of surgery is contemplated, does this patient have a risk for reflux or a risk for Barrett's in the long run? So all of these go into the analysis and the decision-making as to what the procedure should be. The second thing that I wanted to talk about is around the time of the surgery, or if endoscopy in itself can be the primary surgery. And this is a diagram or a cartoon of what an endoscopic sleeve gastroplasty looks like. This is a device that goes and attaches to the tip of the scope, and there's this plicating device that attaches as well. All of this goes into the patient's stomach, and when it's there, we essentially place full thickness sutures, as you will see there, all across the stomach lining on a certain axis. And the idea is that as you pull or cinch these sutures, you're reducing the stomach capacity, as you will see. This is a 90-minute to a 2-hour procedure. The patient goes home the same day, and generally there are certain results that we'll go over that come with it. This procedure, the video that you're seeing, and there you can see the stomach being cinched very nicely. This actually leads to a significantly decreased gastric capacity, almost up to 80%, as you can see there, which is the cause for early satiety. But this is not the only mechanism. And I'll go over the other aspects of this. The coming out party for this procedure happened about 3 years ago. This paper that you see before you was published. It's called the MERIT trial in the British journal, The Lancet. And that suggested that there was approximately anywhere approximately to 16% average total body weight loss that was found to be durable. Now remember, this publication was about 3 years ago. Since then, 5-year data also supports this. So there is significant weight loss associated with this. The other aspect, the other mechanism of weight loss is motility. So in these 3 red images that you're seeing, the first red image on the left is the red area is the part of the stomach that is still retaining motility. In other words, it can squeeze and push food forward. So the first image on the left is baseline, before any kind of procedure. Most of the stomach, or almost all of the stomach, is red. The second one is gastric accommodation and motility 3 months after the procedure. And the last one is the same 12 months after the procedure, where you see very minimal red. So in other words, the dysmotility hits its peak approximately a year after. And this is very important because when you combine this procedure with anti-obesity medications, some of the medications that Dr. Ali was talking about, and we're talking about the older variety, the phentermine, that class of medication was used in this paper a year out from an endoscopic sleeve. And the data suggests that the weight loss was approximately total body, excess body weight loss was about 21%, which are very, very good numbers. When you consider the cost effectiveness of this procedure, usually for class 1 obesity, which is BMI up to 30 to 35, this is the most cost effective. In addition, how does this compare with GLP-1s? We know that GLP-1s are fairly expensive. So for them to be comparable in terms of cost, GLP-1s have to be reduced in price to about 1/3 of what they are today. So if this procedure is so good, why doesn't anybody know about it? That's really the question. The reason is that insurance coverage is minimal. But this is all about to change. Starting January 1, 2026, multiple more insurance companies should come online because this is going to get a CPT code from CMS. In fact, 2 insurance companies have already approved this, Cigna and Kaiser. So we are already seeing an uptick in numbers, especially for Kaiser, that we have Kaiser physicians here. So we're seeing their numbers go up. And I think this is a sign of things to come. Moving on, based on those time points that I was talking about initially, I wanted to talk about early complications. We rarely see them at our center because our surgeons are excellent. But here and there, this data is described. Early complication management, especially with a sleeve. So this banana-like structure that you're looking at, this is what a sleeve looks like. Those blue bubbles are where the sleeve has leaked. That is the fundus of the stomach. This is the weakest part of the stomach. And usually when there's high pressure further down, things back up and the weakest part splits open and it gives way. So in this image, you're seeing what I see when I do the endoscopy. So that pus discharge, that gap that you're seeing, that's where the leak is. So how do we fix this? How we fix this is you see this blue pigtail type device. That's a double pigtail stent that you place into the leak, out into the peritoneum, and essentially through capillary action, it pulls all the mucoid material, the pus, into the stomach, and it slowly discharges it. And then this mesh-like device that you're seeing covering the sleeve is what I subsequently place on top of all of this to essentially seal off the whole area so that the food and liquid can transit without leaking further. Having said that, I wanted to show you a video of how we do this. So to orient you, well, that's me, first of all, and we're in the stomach, and we're looking into the stomach, and this white device that you're seeing is the stent that I will deploy, that you can see for yourself how that works. So this is a fully covered stent. I'm doing this under direct visual guidance. So you see how it flowers up like a balloon, and as I slowly pull back, I'm going to show you where the leak is. So there we go. So you see this area? That's where the leak is. So as I play this video further, you'll see that the stent will cover it completely as I come back out. And we're now into the esophagus. So we're creating essentially a bypass over this area, and the stent has been deployed, and the food should be able to pass without going into this leak. I'll pause that. Now, what are the complications that can happen months to years after surgery? In this picture, essentially what I'm showing you is an anastomotic ulcer. This is what Dr. Salame had shown or talked about. There are multiple things that can happen after years from a procedure. I can't go in all of them based on the time, but I'll try to talk about a few. They're broadly categorized into revisional procedures, things like strictures, bleeding, fistulas, ulcers, and then finally, access. So in somebody who's had a gastric bypass, how do you do an ERCP? Because an ERCP is a procedure that we do to get bile duct stones out. These patients tend to get a lot of bile duct stones, but their anatomy does not support the passage of a scope into the duodenum. So how do you do this? We'll talk about that. So let's first talk about gastrojejunal anastomosis strictures. So when somebody has had a bypass, their stomach pouch is connected to the small intestine. That area sometimes becomes very, very small. That picture that you're seeing is for one of my patients. This diameter is about 6 millimeters. This is really, really small. And as a result of this, patients come in with nausea, vomiting, they're miserable. And a lot of times, we can offer endoscopic interventions, which I'll show you. We place this short lumen-imposing metal stent across this stricture. The idea is that this stent will cause stricturoplasty. It will pull apart the anastomotic stricture over a period of time. We leave the stent in for a few months. You see that white tack? That's a little suture that I placed there endoscopically that'll keep the stent from migrating one way or the other. And then I come back after a couple of months, I take the stent out, and you have a nice open anastomotic area. Other things that we do months to years after are revisions. So on the left side, Dr. Salame showed you a really nice video of how he went ahead and did a bypass. So you're seeing the bypass anatomy. You see the little pouch connected to the small intestine. On the inside, where it says dilation of the GJA is the gastrojejunal anastomosis. It's really wide open. So as a result, when patients eat, food does not hang around in the pouch. It goes straight down into the jejunum, and the patient, as a result, starts gaining weight. So we go in with the same device that I was showing you with the sutures, and we make the mouth of that stricture or the anastomosis, we stricture it down to that size. It's puckered up, so it gives the patient early satiety, essentially causes them to start losing weight again. The other procedure that you're seeing here is for patients who've had a sleeve and they've regained weight. So when we do the sleeve, right after the sleeve, the patient's stomach looks like that, up there. But sometimes after a few months, it turns into this jelly bean shaped thing where they lose the satiety and their surface, the gastric mucosa essentially stretches out. And again, the patient starts gaining weight. So we go in with the same device that I showed you, and we stitch it up, we cinch it, and we get something akin to what we would like again. So how effective are these procedures? They're quite effective. The data is anywhere between 8 to 11% for a TOR, which is the outlet reduction, to almost 13% for a sleeve revision. The last thing I want to talk about is how do you deal with bile duct stones after somebody's had a gastric bypass. This is actually a very big headache for people like me. The issue is, this is the anatomy we are to deal with. This is what a gastric bypass looks like. And in order to do an ERCP, I have to get to the bile duct. How do I do that? Because the duodenum is no longer connected to the pouch. Well, somebody about 7 or 8 years ago came up with this very ingenious idea of doing a procedure called an EDGE, where through ultrasound imaging, through the scope, a stent is placed between the gastric pouch and the remnant stomach. And this stent acts like a bridge. The scope actually goes through the stent, and you follow the blue arrows, like the yellow brick road, and you end up in the biliary tree, and then you do the ERCP. Now, that's all well and good. That looks great on paper. But the issue is that for the scope to make that right turn into the stent is not always easy. We try our best to make sure that the stent's location is in such a way that the turn can be made, but it's not always easy. So here at VHC, we did some research into this, and we've tried to make this easier. We published earlier this year, where we can put a fully covered, one of those longer stents that you saw, through that tiny stent and make a ramp. And the ability to do this particular procedure becomes much, much easier. Thankfully, I haven't had to do this too many times here, but if we do, we have an easier route. And that's about it. I hope I made it in 15 minutes. So thank you very much. Thank you. All right, very good.
All right, good morning, everybody. I'm Steve David. I'm one of the bariatric surgeons in the program here. Unfortunately, I have somewhat of a non-surgical topic this year, so no cool videos of surgeries, but an important topic nonetheless. James Clear, the famous author of the New York Times bestseller Atomic Habits, wrote, "You do not rise to the level of your goals, you fall to the level of your systems." Obesity care is a perfect example of that. Our patients don't necessarily fail because they lack motivation. They often fail because our systems have been siloed. Medicine, surgery, nutrition, psychology, each work independently, and patients often fall through the cracks. Here's a number that should stop us all in our tracks. In the United States, over 40% of adults meet the criteria of obesity today, but fewer than 1% of those patients actually receive comprehensive team-based care. Think about that. 99% of patients are left alone or don't seek treatment for their chronic disease. I'll be discussing how we've created an integrated approach to obesity care here at VHC, bringing together medical, surgical, endoscopic, psychological, and nutritional disciplines together. My topic today is multidisciplinary care, approach to obesity care, putting it all together, because after all, obesity is not just a surgical disease or a medical one, it is multifactorial. No disclosures. The challenge we face: obesity is a chronic, relapsing, and multifactorial disease driven by biological, behavioral, and environmental factors, as we've seen today. Yet the traditional obesity care system remains fragmented. Separate medical, surgical, behavioral silos that don't communicate effectively. This fragmentation leads to inconsistent guidance as patients receive conflicting advice from different specialties. It results in poor coordination as patients often bounce between different treatment teams without a unified care plan. The end result is suboptimal outcomes with high rates of weight recurrence and patients often feeling abandoned by the system, resulting in high attrition. In 2020, the American Association of Clinical Endocrinologists, the American College of Endocrinology, ASMBS, Obesity Society, and a couple other societies came together and co-sponsored the Mechanic et al. Clinical Practice Guidelines. What this did, they redefined obesity as an adiposity-based chronic disease, meaning it's not just a cosmetic issue, it's a chronic metabolic disorder, which, like most chronic diseases, requires lifelong management. Additionally, these guidelines call for a true team-based model. surgeons, medical bariatricians, psychologists, dietitians, other specialists, each playing a specific role at different stages of the patient's journey. And importantly, surgery is no longer seen as a one-time event, an isolated endpoint, or last resort option anymore. It's part of a continuum that includes pharmacotherapy, lifestyle therapy, behavioral support, all tied together with one structured long-term follow-up plan. Our bariatric and metabolic program here at Virginia Hospital Center is built on a comprehensive multidisciplinary approach. We've designed our program to break down the traditional silos, fragmented care, and create seamless care pathways for every patient. This integrated model aligns with national guidelines for best practices in bariatric and metabolic care. The key element of our program includes a range of specialized services, as you've all heard this morning, and a collaborative team of experts. By taking this holistic approach, we were able to deliver personalized, high-quality care that addresses all aspects of our patients' health and wellness. Our comprehensive care approach is built on 4 key pillars: medical management, surgical and endoscopic treatments, bariatric psychology, and a dedicated dietitian team. The medical management pillar focuses on advanced pharmacotherapy, including GLP, GIP agonists to optimize metabolic health. The surgical and endoscopic treatment pillars offer a full spectrum of options, as we've heard. The bariatric psychology pillar provides critical support through cognitive behavioral therapy, behavioral modification, readiness assessment, and ongoing behavioral follow-up. The dietitian team delivers comprehensive nutritional counseling, structural meal planning, long-term postoperative dietary guidance to ensure long-lasting success. Together, these 4 pillars form the foundation of our holistic, patient-centered approach to comprehensive care. In our program, patients can enter through any door, whether they start with the medical bariatrician, the surgeon, or the endoscopist. They eventually have the support of the entire team. Integrated care model ensures seamless, coordinated treatment across all of these specialties. Shared electronic medical records gives every team member complete patient information from the start. Multidisciplinary case conferences for complex patients align treatment goals and determine optimal therapy sequence. There is smooth transition between surgery, medical bariatrics, endoscopy, nutrition, and psychology based on each patient's individual needs. Comprehensive patient education empowers them to actively participate in their own treatment decisions, and this integrated approach leads to better outcomes and overall higher patient satisfaction. The patient doesn't feel passed around from specialty to specialty. They feel supported and unified by the team that's collaborating on their behalf. There's not a whole lot of data on sort of this multidisciplinary approach that incorporates all of these categories that we're talking about today. But there are some studies, and most of them have sort of been within the last 5-ish years or so. The first by Spadaccini and colleagues evaluated outcomes in patients managed through a coordinated team approach involving surgery, nutrition, psychology, and endocrinology. They found that when care was structured and integrated across specialties, patients had significantly better adherence to nutritional protocols, greater weight loss durability, and fewer postoperative complications. Essentially, teamwork translated into better long-term outcomes. The second study by Su et al. In patient education and counseling focused on patient education and engagement, and it showed that when patients receive information and counseling from multiple disciplines, but in a unified way rather than separately, they develop a clear understanding of expectations, demonstrate better adherence to behavioral challenges, and express higher satisfaction with their overall care experience. So together, these findings reinforce what we see in practice, that multidisciplinary collaboration improves both the science and the patient experience of bariatric care. This is exactly the model our program follows: integrated, evidence-based, and patient-centered. The Allegheny Health Network, led by Eid and colleagues, created what they describe as a comprehensive multidisciplinary metabolic center. Their goal was, again, to eliminate the fragmentation that typically exists between surgical and medical weight loss programs. In this model, the patients were initially assessed by weight management, a specialist person who coordinated inputs from surgeons, obesity medicine physicians, endocrinologists, dietitians, and psychologists. A standardized treatment algorithm built into their EMR guided the decision towards medical therapy, injectables, or surgery based on their various BMIs, phenotypes, response, and patient preferences. And every patient, regardless of the treatment pathway, received nutritional counseling, behavioral health input, and physical activity guidance. This ensures that lifestyle and behavioral support are consistent across all treatment options, regardless of where they're at. And these were kind of their outcomes, which were fairly compelling. About 1 in 4 patients who initially chose medical management ultimately transitioned to surgery after limited weight loss success. This highlights the strength of a dynamic, algorithm-based system that allows escalation of therapy within the same coordinated team. Interestingly, those who converted to surgery tended to be older and had much higher baseline BMIs, precisely the population that benefits from a more personalized multidisciplinary assessment rather than a one-size-fits-all approach. The program also demonstrated financial sustainability for their system. Embedding decision support algorithms in the EMR improved communication and follow-up among team members. Overall, the AHN model provides real-world proof that a structured, multidisciplinary model not only aligns with best practice, but also enhances patient engagement, outcomes, and patient growth. Patient story 1. This slide highlights kind of the real-world evolution of one of our patients who initially underwent sleeve gastrectomy before our multidisciplinary program was fully established, then later re-engaged through our integrated care model to achieve results that eventually far exceeded surgical predictions. She initially entered through the surgical pathway in 2020 with a BMI just above 35 with type 2 diabetes and a hemoglobin A1C of 8.8 along with some other comorbidities. At that time, surgery alone was her primary intervention. She had a sleeve in October 2020. The MBS AQIP calculator predicted about 45 pounds of weight loss down to a weight of 168 pounds and a BMI of 27. Instead, she exceeded that. She reached to as low as about 150 pounds down to a BMI of 25 within the first year. Excellent short-term response, typical of motivated patients early post-op. However, over time, she experienced gradual weight regain to 180 pounds, BMI of 30, with a rise of her hemoglobin A1C to 9.6. She represented with diabetes relapse, and that sort of became the turning point of prompting her entry back into our Back on Track program. Under the integrated model, she worked with our bariatrician, started on Mounjaro. The focus was not just medication, but comprehensive reinforcement of behavioral and lifestyle strategies. I just saw her this past week for her 5th year visit. She now weighs 133 pounds, down to a BMI of 22, and achieved a hemoglobin A1C of 5.9, better than her surgical nadir and dramatically exceeding all initial predictions. This underscores the value of pharmacotherapy plus behavioral and nutritional integration, even after surgical plateau or relapse. This case exemplifies how multidisciplinary rescue, if you will, can reclaim long-term success in patients who otherwise might have been labeled as surgical failures. This is her before surgery, after surgery. Fortunately, I don't have a picture before she got back on the Back on Track program, and the last one is her this year. Patient story 2. This patient story is the reverse of the previous one. He began medically and then transitioned to surgery after full behavioral and metabolic optimization. It demonstrates how front-end multidisciplinary management can create the foundation for durable success. Initially, he presented in 2022, 38-year-old male, nearly 400 pounds with a BMI of 59, long-standing weight struggles, yo-yo dieting, binge eating behaviors that was somewhat undiagnosed at the time. He entered the bariatrician pathway through medical management rather than surgery. He was started on Ozempic and engaged in structured psychotherapy for binge eating disorder, along with intensive dietitian follow-up. Over 6 months, he achieved nearly a 10-point BMI drop from 59 to 49, even before entering the OR. In May of 2020, he underwent the sleeve gastrectomy. Again, based on the MBS AQIP calculator, he was predicted to lose about 112 pounds of weight, down to a BMI of 39. He achieved that within the first 6 months, reaching a BMI of 39, well ahead of his predicted timeline. He continued to maintain close follow-up with all the disciplines. There was no handoff from one phase to another, rather continuous collaborative care pathway. Currently, the patient is down to 243 pounds with a BMI of 35, 153-pound total weight loss, way more than predicted with just surgery alone. So while the first patient showed sort of rescue through integration, this one shows preparation through integration, the same model applied earlier, leading to safer surgery and lasting success. More evidence. This is a systematic review by, I'll just say Sundar et al., who analyzed about 30 studies on the multidisciplinary obesity treatment programs, evaluating their impact on weight loss, metabolic improvements, and surgical outcomes. And basically, the key findings show that integrated care, combining nutrition, behavioral modification, pharmacotherapy, and surgery, produced the greatest and most durable weight loss, with average reduction of 8 to 15% versus 3 to 7% in non-integrated single-discipline programs. Behavioral therapy, such as cognitive behavioral therapy and motivational interviewing, significantly improved treatment adherence and reduced the risk of weight regain by addressing psychological barriers. The integration of pharmacotherapy and combination therapies, enhances success rate when combined with structured lifestyle programs, demonstrating synergy between this. And finally, bariatric surgery did remain the most effective single tool with best outcomes. However, it's even improved or even better when supported by ongoing multidisciplinary care, confirming that integration, not intervention alone, is a key driver of long-term success. So to conclude, the authors emphasize that multidisciplinary chronic disease management is the most effective and sustainable approach to obesity care compared to single therapy management. Shared decision-making is a critical element of patient-centered obesity care. It ensures treatment plans align with patient values, preferences, and life circumstances. It builds trust and reduces post-treatment regret by aligning expectations. Research shows that shared decision-making leads to higher patient satisfactions and better long-term adherence. This slide outlines the key elements of a comprehensive obesity treatment framework. The ABCD model that we talked about earlier provides a structured approach to assessing and treating every patient. Patients can enter through any door, nutrition, medicine, surgery, or psychology, and immediately access the full range of care. All specialists collaborate closely to deliver coordinated care. We strategically combine multiple treatment modalities, behavioral, pharmacologic, endoscopic, surgical, to maximize long-term outcomes. And research shows that this integrated approach achieves the highest retention rates and total weight loss and higher patient satisfaction scores as well. So based on kind of the few studies that we've sort of looked together, if we look at outcomes across all modalities, certainly the integrated approach combining medicine and surgery increases retention rates and outcomes. So to summarize, the integrated care provides best long-term durability, patient satisfaction, and clinical outcomes. Our model here at VHC emphasizes collaboration rather than competition between treatment options, and they all complement each other.
That was great. Okay, well, let's invite the speakers up here, and we'll go ahead and take some questions.
Is there a slide I show you?
Okay, questions? Yes.
Regarding the endoscopic sleeve talk, do you have any statistics on the percentage done by gastroenterologists versus bariatric surgeons?
Yes. So generally, in this part of the country, there's 4 endoscopic centers that offer this procedure. Right now, all of them are not covered by insurance. They're all cash only. And all 4 centers are serviced by gastroenterologists, none by surgeons.
Is the Dr. Hack, is the endoscopic sleeve gastroplasty, is it reversible though? Because I know you just cinched the inside.
No, it's not. These are full thickness sutures, so they go through the whole stomach lining, and they're essentially meant to stay, just like a surgical sleeve.
Yes.
With the multidisciplinary approach, say someone comes in and their BMI is high or whatever, and they've got comorbidities. Is it dependent on what the patient wants, or would you look at doing the pharmacological phase first, see how much they could lose with like the GLPs and stuff like that, and then if they were at a standoff, then transition them to surgery, or do you do it vice versa?
So ultimately, a lot of the treatment plan is driven by the patient in terms of what they prefer. We present them with all the options. If someone is starting out really high in terms of a BMI, for example, that second patient that I showed, no single management is going to get them to a normal BMI. The goal is just to try to maximize weight loss. So oftentimes patients just know they want to start with surgery, and we'll just, plan for surgery. This patient, in 6 months itself, was able to accomplish a lot medically, had surgery, and then got back on medications afterwards. But oftentimes it's going to come down to whatever the patients sort of prefer. Does that answer your question?
With, say like they had the surgery and
Yeah.
stuff, and then they've done the weight regain.
Yeah.
Instead of having a revision done or whatever, would you look at then putting them on the GLP to see
Yeah.
the weight loss?
So that was that first patient, had surgery, lost weight, regained, went to our back on track. Now she did really good. Her weight to begin with was on the lower side, so she's great over there. She doesn't need any surgery. But let's say her BMI was much higher and she went through our back on track program, lost weight, but her BMI was still elevated and she still needed to lose more and plateaued with medical management. Then at that time, we would consider additional surgical revisions. For example, if a patient had a sleeve, at that point, we could potentially consider doing the SADI procedure that Dr. Salmi talked about, and that will give her even more. So it's surgery, medication, more surgery, more medications. Yeah.
When you're doing the, either the sleeve or the SADI, whatever, and the use of the GLPs, is it kind of contradictory because there's that, the gastroparesis slowdown? Does that create problems for them afterwards because you're doing the sleeve and you're already reducing the stomach size and all? Like,
I haven't
more
seen that,
problems
and on.
with these?
Yeah, no, it's a great question. I haven't seen much of that, to be honest with you. I actually think, and I think we've noticed this, that patients who have had, particularly a sleeve, actually tend to do better with the GLP-1s than patients who have not had surgery. And it maybe has something to do with the anatomy and kind of how the motility is affected. And then one thing I just wanted to add in terms of your first question was, we don't have like a firm cutoff, but generally if someone's coming in with a BMI over 40, and they're coming in to see Dr. Usman and I, we almost always will introduce the conversation about surgery and recommend that they talk to Dr. David or Dr. Salome. Whether or not they do, we don't try to push it, but we do want to sort of plant that seed. And definitely if their BMI is over 50, that, hey, like a combination approach is probably going to give you the most success in the long run. And that's, I think, the strength of having the team is that there is still sometimes this idea that surgery is the last resort, where it sometimes could be the primary therapy, and sometimes maybe it should be the primary therapy, but there's a lot of stigma either that the patient has or that they've been told from their other doctor, whatever it is. So I think that education piece is really critical.
And to your point, that second question as well, no contraindications as such if they've had bariatric surgery to get on these medications, but sometimes it can make things a little more complicated in that the patient's had sleeves, having some reflux, has some constipation, but now we're trying to optimize and get more weight loss. Well, their reflux gets worse because they're on Ozempic, their constipation gets worse. So having sort of a team that we can kind of talk about the patients, in the hallways and kind of run things by each other kind of is helpful. Oftentimes there's a patient that's had prior surgery, they're on the medical pathway now, and our side's like, well, this patient's having a lot of reflux or having dysphagia, I'm not sure what's going on. We'll see him, kind of figure it out, see if mechanically there's an issue or not, if the medication needs to be changed. So I think those are kind of the helpful features of being able to run things off each other on the same team.
I feel that sometimes they respond to the GLP-1 with low dose even. You don't have to maximize the dose. They have very good response with the lower doses.
With those GLPs, can people eventually just get off of them and not have the weight gain? Or is it just like once you're on it, it's pretty much lifelong because...
Yeah, go ahead.
GLP-1 approved for long term, lifelong, basically, because the risk of the weight regain if they go off the medication. So is approved for lifelong. Patient always asking that question, but as I explained earlier, the set point and the people, they will regain the weight back. They did the study on the GLP when they took them after they reached to their goal, and 50% they regained the weight back. So that's high risk, and you know that they're going to regain. So we have to explain to them why they need to be lifelong on the
Are the
medication.
insurance companies covering it more because a lot of it's been out of pocket to be placed on those for weight loss?
I would say around here, this is a conversation we're having all the time, but it's probably like maybe 50% of insurers around here, I would say, if I'm just going to take a number off the top of my head. I think the statistic is nationally it's less than a third of insurers cover this drug, which, as Dr. Hawk mentioned, is definitely a barrier, big barrier.
Thank you for a wonderful conference, really spectacular and great videos. My question is about the journey to integration. How did you get there, particularly with specialties that could potentially compete with each other?
Most interesting question.
That's a fantastic question.
So I'll tell you a little bit about how I happened to pop up in this program. I think they'll answer the question. So when I came here, I came from a different organization, local organization, where bariatric endoscopy was considered the stepchild. And we had bariatric surgeons, but they didn't really want to work with us. When we came here, I was welcomed by Dr. Salome and Dr. David and the whole program. I think early on, what they knew was that when I joined the program as an advanced endoscopist, I'm not taking from the pie. I'm adding to the pie. So every service has a halo effect. It creates work or business around it. So if I do an endoscopy, there will be situations where I require surgery and vice versa. So I think the foresight existed, and when I interviewed, they saw the potential, and I guess we recognized each other, that this can work, but it required them to welcome me, which they did. So as a result of that, I think the answer to your question is, they saw things well before probably other people did. So I think that is the difference.
No, thank you.
Yeah,
And I was going to say, yeah, I mean, the key, 100%. The key is not seeing the specialties as in competition, right? The key is to put patients first and what is best for that patient. And we started this program long before a lot of these studies came out, and kind of seeing that ultimately you have to work together in that ultimate goal, and looking at obesity as a chronic illness, and it's not going to be one cure. None of these therapies is going to cure the patient. Not the drugs, not the surgery, not the interventions. None of them is going to be curative. We have to kind of add things and work together. And unfortunately, a lot of programs here and around the country, I mean, sort of work in silos, as Dr. David said, right? You got obesity medicine who will continue treating that patient and over and over again, trying different things, selling them various things, and never consider any other therapy, right? So if you put the patient first and create these algorithms and figure out what's best for the patient and work together, that's when you achieve success.
Just to piggyback off of that, I think it's just about mindset in terms of how you look at it. You can look at it as competition, but I mean, some of the Allegheny Health Network data that I showed earlier, oftentimes patients kind of don't know what they want, and if they're in a single program, they kind of just keeps going through with that. But when provided with all the information, there is a lot of patients that cross from one modality to the other because they have the appropriate knowledge and education, and eventually I don't think one specialty ends up stealing patients, if you will, from another specialty. Rather, there's a sort of a lot of cross kind of movement of patients from one to another.
Absolutely. Yes.
I have a question regarding this is related to patients who have a history of gastric bypass or any bariatric surgery. For all of us who are prescribers in any field, what do we need to consider for these patients when making medication choices? Like, how do these surgeries affect the pharmacokinetics of these drugs?
Yes.
Do
No,
we
it's
have to avoid certain types of drugs like extended release?
No, it's a good question, and honestly, we probably do not know how these affect every single drug, right? We just don't know. But for the most part, you don't have to make changes to prescriptions. You can prescribe things exactly the same. The only, as I mentioned, avoiding NSAIDs and aspirin and steroids in patients with gastric bypass because of the risk of ulcers. But in general, you're looking at the effect of the drug, and if you have to modify the dose based on that, you might need to. But there are no guidelines when it comes to that. Now, I would say if we see somebody who is having a kidney transplant, let's say, is on immunosuppressants or on other drugs that are like critical, we will try to avoid surgeries that are creating any sort of change in the absorption. So for those patients, we will probably do a sleeve when we see them for the first time. So when they're on critical drugs, so we try to avoid affecting the absorption. But people develop things down the road, right? And you have to prescribe new drugs for them. And I would say you'd prescribe them like you would normally, and you will just monitor the effect. But we don't have any studies or data on every single medication and how it's affected by drugs. But for the most part, honestly, the drug absorption is not drastically changed. Anybody wants to add to that?
Yeah, I think the only thing just to add would be it's maybe more something you would be more careful with drugs that have a like the dosing effect needs to be more finely tuned. Something like digoxin or lithium or something like that, where you are monitoring the levels anyways, because like small changes could make a big difference. Those would be drugs maybe I'd be a little more, because I have had conversations with a lot of psychiatrists actually about lithium specifically. So Dr. Salman's point, we don't actually know, but it would just be in those drugs that are a little more, you have to be a little more careful in their titration. Those would be ones I'd maybe be more mindful of. But in general, like you mentioned, you don't really have to change dosing very much.
I just wanted to know, outside of decreasing the cravings, is there any other indication for contrary?
Just generally for weight loss.
Okay.
Yeah. So it doesn't have to be just for cravings, but maybe sometimes if they can't use one of the other drugs, it's contraindicated for another reason, it can just generally help. It's FDA approved for weight loss in general.
Awesome. We'll take one last question. Actually, two. You had a question too, so we'll take two questions. Yes, go ahead.
I was just curious to know a little more about what would you do with patients that have a BMI above 50 and have tried the GLPs and Zepbound and like they've tried everything and they're not losing, or had a history of bariatric surgery 10, 15 years ago, had lost, came back. Does it have to do with the set point that for some patients they always will be skewed toward the higher BMI, or should we wait for those higher potency GLPs, or just like to have your ideas about that?
So when the patient BMI above 50, I mean, this definitely surgical option, or if they had surgery in the past, will be considering revision. But we start with medical treatment, GLP-1, and we try to reduce the weight. I don't know, but from my experience, I feel when the BMI more than 45, 50, they don't respond to the medication that well for some reason. I mean, what I read that like the GLP is absorbed, the absorption is less for this patient because it is injectable at the end. So the amount of GLP getting to the system is not that, it will not be effective. So I think multidisciplinary approach of surgical, medical, and the dietitians, the psychology, and everything, that will be helpful.
Yeah, I completely agree, and it kind of really depends because I kind of wish Michelle was part of this panel.
Our
The
psychologist.
number in and you'll hear on the next round, but some of it is not just as simple as just the numbers. Like, what kind of education did they receive surrounding their medication? Were they just seeing somebody that prescribed them a GLP-1 agonist every couple months and that's it? Do they have undiagnosed binge eating disorder that they never? So I think there's a lot of nuances to it. So especially when we're seeing these patients such high BMIs, they've had prior surgery and nothing worked. We kind of start from scratch. I mean, that's what our Back on Track program really is just you start from scratch, start off with a psychologist from basic history, things like that, figure out, barriers, things like that, of that nature, what their basic nutritional understanding is of what they should be doing. Are they doing that? Are they not doing that? The barriers to that. Then add on medication and kind of really go through an intensive 6-month program before we figure out whether or not they're even going to get surgery or not. And I tell you, majority of the times, I mean, patients themselves are surprised at their outcomes because they feel like they've tried everything and failed. But again, we don't know what that means. They could have been, siloed programs here and there that weren't really integrated and as coherent or intensive.
Okay, last question for the morning.
So my question is, it sounds really amazing program, but you talked about muscle loss, and is there a way, or did you guys integrate physical exercise, or is there a program for those patients who are in treatment or after surgery? What is the plan for them, because we can't gain muscle loss, once we lose muscle.
So I would say that is probably the only component that I feel like we don't have a clinician on our staff that's managing that. We do have a dietitian who is also a personal trainer that, sometimes we pick her brain for that, but we really do incorporate in education, a lot of information about opportunities for exercise in the area, discounted programs that are offered through the hospital, discounted programs with other facilities that are, just to make sure, because the activity is a very big part of it. And also, and that includes for our obesity medicine patients who aren't having surgery. I don't know what the number is, but that, of weight loss without, how the body composition changes when you don't have that nutritional support that we get from our dietitians. And
And we also, so we track the body composition. So we don't just go based on the weight. We have an in-body machine. I think Dr. Osman talked about bioelectric impedance. So it looks at the body composition. So we're tracking and seeing if they're losing muscle or not. And I don't know if what Dr. Osman has seen, but I've noticed that exercise is crucially important, but almost more important than exercise in terms of whether or not they're going to lose muscle is their nutrition. So if someone is eating adequate amounts of protein, even if they haven't, as long as they haven't radically changed their activity level, even if they're not exercising as much as we'd like them to, I haven't seen actually massive changes in muscle loss. I don't know what you see.
You know, we counsel them about exercise and what they need to do, and we keep reminding them every follow-up what needed. Recommend resistant training and stuff like that. We monitor the muscle loss, and when we see the muscle is down, you know, you make sure they're doing the exercise they're supposed to do. So I believe the counseling is helping, and you know, talking to them and reminding them will be the best for now. We don't have specific.
And your patients do see the dietitians regularly too. Like that's part of the obesity medicine program is you're also supported by the dietitians on, and they provide a lot of information about protein and the nutritional needs that they have to make sure that you aren't just excited about seeing a number on the scale, that you really are getting a good picture of what changes are happening in your body.
I'm going to say one
Yeah.
last thing. This panel tends to inspire its patients. By example, this gentleman here is a triathlete. So when this handling patients, I tell our patients, the guy who referred you is a triathlete, please follow his example.
And of luck to VHC Health, we do have a number of community sort of classes, exercise classes that are designed for patients who maybe try and exercise for the first time, low impact classes, et cetera. So a lot of opportunities here for patients to take advantage of that. So with that, let's go ahead and take a break. Should we say 10:25 we'll reconvene here? Would be great. 10:25?
Let's do it.
Thank you.
So to kick off our first presentation for the second part of our morning, we have one of our fabulous dietitians, Brooke Schneid, is here, and she'll be covering dietary interventions for long-term weight loss.
Do I need this to move the slide?
You can use
Okay.
the arrows on there too.
Okay, perfect. Hi, everyone. I won't say good afternoon yet, but it's probably felt like a long morning so far. My name is Brooke Schneid, and as Lynn said, I'm one of the registered dietitian nutritionists here in our Bariatric and Metabolic Health Center. I'm one of two, and my colleague Laura is here as well. And we support all of our patients that come into the program, whether they're coming in seeking medical treatment or surgical treatment. And so today I'm going to talk about dietary interventions for long-term weight loss. And when I think about interventions, I think about the nutrition intervention a little bit more holistically in terms of our approach, and I think about interventions in terms of the specific recommendations that we make to our patients. So I'm hoping to get at a little of that, a little of both of those things today, not so much the specific healthy foods that we recommend, but we'll incorporate some of that along the way. I have no financial disclosures. And as far as today's objectives, the first would be to examine the dietary implications of weight loss medications and surgery. The second would be to establish goals of nutrition intervention. And the third would be to identify the key dietary strategies to optimize the long-term success of our patients. So the first thing I wanted to look at is the dietary implications of these medications and surgery. And one of the things that has been interesting for me on a personal level is that I've been counseling bariatric patients for over a decade and really familiar with what the dietary implications are there, but just had the opportunity to see the volume of patients on these medications in the last 3 years or so. And what I've seen is that the implications are really the same. And the only real difference that you'll see here is the phased diet approach that we use in the early post-op period with our surgical patients. But in general, all of our patients, at least acutely in the early post-op period and as they're starting and transitioning on these medications, are coming in with various degrees of decreased appetite, reduced intake as a result, early satiety, feeling full quickly, and varying degrees of GI distress, whether that's complaints of nausea, vomiting, diarrhea, constipation. Food aversions present themselves in both scenarios as well. So with our surgical patients, we have some really specific food aversions that tend to be common, like the taste of sweet things tastes sweeter, the taste of water maybe is different. With our medical patients, that could be a little bit across the board, just kind of general foods don't sound as palatable. They kind of don't know what to eat. Nothing sounds good. And then also some protein sources, which is really important, are tougher to get in as well. And for all of these reasons, we have a risk of malnutrition and a risk of dehydration as well. So it's not just about the weight loss. We really want to make sure that we're preserving their nutrition status as well. The overall goals of our intervention, of course, are to optimize nutrition status. So, of course, we wouldn't be successful if we promoted weight loss, but we didn't ensure they were getting the right amount of calories and protein that they need, and that we were monitoring their micronutrient status and sort of bridging the gap between what they're getting through their diet and supplements. Optimizing diet tolerance, so again, just using strategies to prevent nausea, vomiting, and alleviate that in some cases, prevent constipation, and then troubleshoot the preferences due to those food aversions and making sure that we're giving individual recommendations for them to find foods that work. And then, of course, we want to support their long-term outcome. We want to support weight loss and weight loss maintenance. And that has a lot to do with our ability to preserve their lean mass or their resting metabolism along the way. So, of course, I want to hone in on the dietary intervention piece, which is where we sort of set our goals together. But I thought it would be helpful to put this intervention into context as far as how our overall process works, because every piece of this puzzle helps us arrive at the right interventions for each patient. So the nutrition care process is essentially a 4-step process comprised of assessment, diagnosis, intervention, and then monitoring evaluation, which is our follow-up. And in the assessment process, we spend a lot more time with patients in the initial visit to collect as much background as we can, right? So we use an hour-long visit initially. We look at, of course, their anthropometric data, so their weight, their height, their weight status, all of those sort of metrics, their BMI. If we have access to their in-body data, we'll look at that. Their medical history, so of course some elements of their medical history might have implications for the dietary intervention. Diabetes is a good example of that. We look at their social and lifestyle factors. This might have to do with their work schedule, whether they're eating foods at home mostly or eating out mostly. Are they cooking for themselves? Is someone else in the household cooking? That might include exercise. What's the frequency and duration and intensity of that, I think is relevant. And then, of course, we spend a lot of time looking at their dietary intake. And we always tell them, look, we're going to do our best to capture a snapshot in time, but let's go through what reflects your most typical intake. And that allows us to start to understand what their intake looks like in the context of their lifestyle and to start to learn their food preferences as well. So from there, of course, we identify the problem, the priority problem, and with our patients that might just be this chronic overweight or obesity, it might be inadequate protein intake, things like that. But of course, the focus of our talk today is the intervention. And this is where we are leveraging evidence-based recommendations that target modifiable factors, but really trying to be specific. And the focus is on small, sustainable changes over time. And that really necessitates that monitoring and evaluation. So the follow-up is essential, right? And I think we're really lucky, and it's unique in this situation that we have the opportunity to build rapport with our patients over time. So what is evidence-based as far as dietary interventions for weight loss? Of course, we need to factor the amount of food consumed, the type of food. There's some evidence around the timing of intake. And then, of course, self-monitoring is a characteristic of folks who are successful with weight loss for the long term, which most studies would qualify that as a year or more. As far as the amount of food intake, we know we need a calorie deficit to produce weight loss, but in this setting, typically that calorie deficit is reliable with the medication, so we usually tell patients, we're not going to start there. We can kind of learn over time how we need to manipulate the calories. And then, with our post-op patients, we have sort of specific goals or ranges that we're working with at different phases post-op, but we're always, as dietitians, kind of keeping a pulse on the total calorie intake. There are situations where underconsumption is a problem. I usually say, you could have all the protein in the world, but if you don't have a baseline amount of calories to support your needs, you would still be at risk of compromising that lean mass. So at some point, we do have to look at just getting a minimum amount of intake for these patients. And there is research to support the use of meal replacements to produce a calorie deficit, but in this setting, we're often using them just to get an intake when that appetite is really severely impacted. As far as type of food goes, the priority is always on protein. We know that, I think Dr. Ali, when I got here, was talking a little bit about that. In the setting of a calorie deficit, we're really trying to drive up that protein to better support the lean mass, which is that metabolically active tissue. It also allows us to leverage the thermal effect of food, which is another sort of sliver of our modifiable metabolism. And with our surgical patients, of course, if we're not getting that protein in as a priority, then we risk crowding out that protein with other foods. And I find the same thing happens with our patients on medication as well. So it's not just increased protein, but protein first at meals. We talk about calories and protein first, and I usually tell our patients, you can think of the calorie goal as sort of the big umbrella, and then once we take care of a certain amount of calories from protein, what's left is coming from a mix of carbohydrate and fat. But that distribution doesn't matter. And I think a lot of our patients are pretty relieved to hear that they don't have to count macros and totally eliminate carbohydrates. And there might be some considerations around that distribution for folks who are maybe more active and would benefit from more carbohydrate to support their output with exercise, or maybe food preferences, right? We have some patients who might just prefer higher fat foods like avocado and olives and things like that. And we would try to support that as well. There are some foods that don't have a place in a healthy diet, and so we look for those red flags, so limiting concentrated sweets, sugar-sweetened beverages, fried foods, and then it's not just sufficient to be getting in the right amount of fiber, but we really try to leverage that, right, for satiety, for volume, and for the micronutrient contributions, particularly when the fiber is coming from things like fruits and vegetables. Timing of intake, there is no research to support any one right frequency of intake. What we're looking to do with our patients is sort of default to 3 meals a day, or at least a minimum frequency of intake to support their protein needs. So there's some debate about whether there's an uptake threshold for protein, whether we can use only so much at a time to support lean mass. But I would say it's pretty rare for one of our patients to be able to meet their protein needs in 2 sittings. So we're sort of defaulting to 3 solid meals. Where else we're looking at is, are there prolonged periods of time between meals where we might be presenting some vulnerability to unplanned eating and snacking and things like that. But primarily we want to support protein needs and help them establish structure for consistency and sustainability moving forward, and I'll talk a little bit more about that in a minute. We want to make sure we're not eating too close to bedtime, and we want to avoid skipping meals because that's a big problem with our patients on medications. And then finally, as far as self-monitoring goes, my patients would probably say I get on my soapbox about the food log all the time. I'm a big believer in self-monitoring. There's tons of evidence to support it, but I just don't find patients do quite as well with the tracking apps. And I just think that, I usually say, when you're logging, it's a little more of an active, reflective process, and we can kind of work through and learn together that way a little bit more effectively. So we're always encouraging our patients to kind of find the right self-monitoring tool for them, but also understand how to make it work for them in the long term. As far as how we apply these evidence-based interventions in our patients, how we individualize these recommendations, we use kind of a framework, right? So we're incorporating all of these things, but we're doing it on an individual level and based on our assessment as a part of that nutrition care process. So once we collect all that information, I think the first question we're asking is, what is that eating pattern going to look like for you, right? And again, no one size fits all. We try to default to 3 solid meals, and we look at the specific timing, right? In our patients who are on medications, having that clock as a reminder is important, because when they no longer have that hunger cue, we need to make sure they have a way to stay on track with their needs. Same thing with our surgical patients. They aren't going to be able to compensate for a lack of protein earlier in the day later on. So we try to help them identify what is the structure to the eating pattern that is going to be most conducive to their lifestyle. And that's not just how many meals versus snacks, but what time. And again, we talk about this as sort of laying the foundation. And this to me means kind of helping our patients arrive to each eating occasion with intention. And if their eating pattern is different every day, then it's really hard to do that, right? So we can say, 3 meals a day and eventually get to a point where we're saying, this is how many calories and protein per meal, and here's what that looks like, right? And here's what that looks like based on the foods that you eat and what you might get if you're out, right? But we can't do that unless we identify that structure first. So we would establish that goal. The second thing, of course, when we think about the protein, is we start to use that structure and identify how much protein per meal or per snack. And if we're defaulting to 3 solid meals, we'll just kind of use that occasion. So we'll say, okay, maybe you need 30 grams of protein per meal. That would be the equivalent of 4 to 5 ounces. And based on the foods you're eating, here are a few specific examples of that. And then again, we'll counsel them to consume the protein first. And the reason why I mentioned those implications earlier is because I think we try to have those conversations with patients ahead of time. Hey, you're on the low dose of the medication now, but we can expect that you're not going to feel as hungry or you're going to feel fuller quicker. And we want them to be proactive about that and kind of guide them into that learning curve. Then, of course, we look at the calories. We get further along in our follow-up. We would maybe be adjusting calories, whether it's kind of helping them get to a minimal amount that's necessary or tightening things up over time. And then, we're usually looking for the lowest hanging fruit in that case, right? So what are the smallest changes we can make that are going to have the biggest impact, over time? Most of the time, when we're counseling our patients to focus on protein, the sort of natural downstream effect of that is fewer calories. And that's really liberating, right, for a lot of our patients to be thinking more about what they need more of and not what they need less of. And then lastly, of course, we're working through the food log, how to make that work for them. We use an approach called record, reflect, revise, which we designed originally to use with our surgical patients. Again, just because we find a food log generates a lot more insight. So we teach them how to make that, how to sort of not need us. And so we teach them to capture a few days, that's the record component, to set aside some time to look back on that and kind of help them understand what to be looking for. And then the revise is their ability to set some goals or make some modifications on their own. So we're not just having them bring back those logs so that we can see what they're eating and adjust, but we're also doing it so that they can learn the tools that they need to support their long-term outcome. And then, of course, troubleshooting, right? With all of our patients, we have to deal with some of these other things that come into the picture with poor appetite. Sometimes we modify their eating pattern in order to support the appetite. So, for example, we have a lot of patients who maybe are using a protein shake first thing in the morning because they wake up without an appetite and they get in the habit of that. But then they have a solid lunch, and by the time they get to dinner, they can't eat, right? They haven't had enough time to develop that appetite. So we might work with them to move the protein shake midday and kind of find a solid meal in the morning, and then that way they're still getting their protein in, but they have a bigger gap between those meals to get in all of their needs at those 2 solid meals each day. Again, we might use protein shakes as sort of a contingency. And then again, we're looking at where we might need to bridge the gap between their dietary intake and supplements to ensure that they're getting in, the baseline levels of vitamins and minerals that they need. If they're really struggling to get in protein, this is a really common complaint. Again, the protein shakes might be a good option. We talk a lot about soft, solid sources that patients generally find a little bit more palatable, maybe less dense in the stomach. So maybe instead of chicken breast, try ground chicken or chicken meatballs, or try baked fish. Or yogurt or cottage cheese or egg whites instead of whole eggs because they're a little less filling and those kinds of things. We augment, so we get really creative with how we're adding protein into foods that they're already consuming and finding ways that we can control the volume of food that they eat. And again, this is relevant for our medical patients and the surgical patients, but get in more of what they need. So maybe we're putting peanut butter powder in a Greek yogurt, or we're having them mix their protein shake with their small amount of oatmeal, those kinds of things. Skipping meals, again, I think the structured eating pattern is really important there, and sometimes we need to modify that. Leveraging mealtime alarms is something we do a lot. If patients really struggling with nausea, we would be looking a little bit closer at the high-fat foods or fat content of the things that they're consuming, which can exacerbate that nausea. And we might consider small frequent meals for someone who is otherwise, on a 3-meal-a-day type of eating pattern. Cold liquids, so manipulating the temperature sometimes is helpful. Ensuring adequate hydration. I do find that some patients do better with their nausea when they realize how little fluid they're getting over the course of the day. Eating and drinking at the same time is something we discourage our surgical patients from doing for a lot of reasons, but this is also relevant with our patients and medication. I find, that they're relying on fluid at meal times. They just generally forget about food and fluid during the day, and so a lot of times we can get some improvement with nausea, just sort of supporting some hydration strategies. Constipation is an issue, I think, for a lot of our patients. Maybe some patients on certain medications are more prone to it than others. Maybe folks who have a history of chronic constipation, really struggle more on the medications. So sometimes we use we recommend a fiber supplement over the counter sort of prophylactically, which is exclusively soluble fiber. It does the same thing that the medication does. So we are very careful that when we implement that strategy that we're doing it gradually, sort of starting with like a 1/4 teaspoon and gradually increasing that. We work on sort of encouraging folks to round out their protein with fiber. So making sure, okay, once you got your protein in, the next thing you need to be getting in is the fiber. And sometimes we have some strategies for that too. We might encourage folks to kind of dice up their vegetables and mix it in, or cook from frozen, which allows the vegetables and fruits maybe have more water content, or wilting spinach into things. So we get creative there too, and always trying to factor in the volume restrictions where applicable. And then ensuring adequate hydration, again, that can be a contributing factor. And then we try to avoid the overuse of protein shakes, which can contribute to constipation for some patients too, whether that's just like an overload of protein or replacing too much solid food. So I wanted to introduce just kind of a simple but reflective case study and show you maybe how we would apply these interventions. And this is a patient who's a 35-year-old male who had a sleeve gastrectomy over a year ago, has been on Wegovy for about 3 weeks. He's coming in reporting poor appetite. He's often skipping meals, partly due to his busy schedule. And the protein shakes are well tolerated. He complains of intermittent constipation and admits limited fluid intake. He reports a 5-pound weight loss over the 3 weeks since starting the medication. He's employed full-time. He's eating foods from home mostly. He is supplementing with a bariatric multivitamin that is inclusive of iron. His intentional physical activity is limited. And some anthropometrics here. I think what would be relevant mostly is the rate of weight loss. So that is one thing that we look at. If he's lost, his overall weight loss since surgery is about 60% of excess, which would be considered a successful outcome after a sleeve gastrectomy. So he's clearly on the medication to get some additional results. And he's reporting that 5-pound weight loss over 3 weeks, which is a really reasonable rate of weight loss, right? About 1.5 pounds per week. So that tells us that the calorie deficit is appropriate, right? He's not got too big a calorie deficit. He reports, I think one of the reasons why I like this scenario is because it's kind of unremarkable in the sense that his intake's not so horrible, but it's not great. But we can still find ways to really make this so much better. His estimated intake, post-op kind of general guideline, 1,200 to 1,400 calories, somewhere between 60 and 120 grams of protein, at least 2 liters of fluid. He's reporting at 8 a.m. a venti iced coffee with half and half and 6 packets of sugar. Mid-morning is grabbing a granola bar. 12 p.m. doing 4 to 5 ounces of chicken and about a cup of rice, and doing the same thing at dinner if he can get his dinner in, right? Because sometimes he gets to dinner and he's just not feeling hungry. We know he admitted limited hydration, so he's estimating maybe a liter we collected, right? So to apply this same framework, again, we would look at the opportunity to establish a structured eating pattern. So here he's got the coffee and then the mid-morning granola bar and then the 2 meals. So we would try to see if we could consolidate. It's clear that he's not getting what he needs at breakfast, which is probably why he's reaching for something mid-morning, or maybe he just feels like he needs to get something in. So we would look to sort of say, okay, can we aim for 3 solid meals a day and try not to go more than 5 or 6 hours between meals? That, in his case, might require moving his lunch a little later so that he can close the gap a little bit between lunch and dinner, or maybe he is opting for a little bit of an earlier dinner. We would look at the protein and say, we know he's not getting enough protein. Kind of go back to this slide. Looked like he was getting about 65 grams of protein a day at a max. So we would look for strategies that are close to what he's doing now. One opportunity might be to replace the half and half and the sugar in his coffee with a ready-to-drink protein shake. And then I would just reinforce that 4 to 5 ounce portion is the right amount of protein at each meal, but he would need to be getting that at both meals. And this is where I might introduce the idea of let's try to replace that half and half and sugar in your coffee with protein shake, and then maybe later we would be able to move that midday if he can't get in his 2 solid meals later on. From a nutrient status, we know that he's taking a bariatric multivitamin with iron. If he adds the protein shake in, he'll get about a third or a half of his calcium needs met, but we would need to add additional calcium, so we would counsel him on that. And then we would also encourage him to round out his protein at meals with fiber, preferably from vegetables, right before the rice. And I would be careful to say you don't need to eliminate the rice, but let's make sure we get the protein in first, and then a good amount of vegetables before we go on to the rice, just knowing that there would be limited capacity for that. We would encourage him to hydrate consistently between meals just to support adequate hydration, especially as we're adding additional fiber. And we would consider an over-the-counter fiber supplement, and I would make those same recommendations for sort of a gradual introduction, just given his struggle with constipation. And then, of course, I would recommend a food log and encourage him to capture at least 3 to 4 days pretty vigilantly, even if they're not consecutive. So that's a good example of how we would take some of those evidence-based interventions and sort of apply them on an individual basis. So some take-home points might be that the dietary implications of weight loss surgery and weight loss medications are very similar. The goals of the dietary intervention are the same. And it's really important that we meet the patient where they are and look at their overall history as well as their individual dietary history. We provide a structured framework. So again, we apply this framework in every visit. So even though we're making changes to their dietary habits, we are helping them learn along the way how to eat for the long term. And of course, we need to brainstorm and troubleshoot on an individual level when we have complications or, individual side effects and symptoms. And my references.
Our next presenter is Dr. Michelle Coleman, our bariatric psychologist.
Good morning. Good morning. Looks familiar, right? All right. Thanks so much for having me this morning. I'm Michelle Coleman, one of the bariatric psychologists, and today I'm going to talk about a topic that's near and dear to my heart, emotional eating. All right. I have no disclosures. All right. We're going to essentially talk about and identify several psychological origins of eating. We'll talk about the the implications for emotion-based eating on weight loss, long-term weight management, and also review some strategies for the management. Okay. We'll talk about what emotional eating is, right? What it's not, how to identify it, common triggers, also not so common triggers, and methods for effectively managing it. So what is emotional eating, right? Show of hands. Emotional eating. What comes to mind?
Somebody's bored.
Possibly. What else? Stress. Right? Stress is a big one, right? Okay. Yes. All right. Kind of grainy, but looks familiar, right? Kind of this is the poster child for emotional eating, right? Haagen-Dazs, Hallmark Channel, right? All right. Emotional eating essentially is eating to get our emotional or psychological needs met. It's not typically in response to physical hunger. It usually is with specific types of foods, oftentimes sweet things, snacky things. I mean, I've been in practice for over 10 years and rarely have I met a patient who emotionally eats carrots. But time is still of the essence. I'm still waiting for that client. It's important to understand that this is a learned behavior, right? We're not born emotional eaters, we learn. And for many of us, it is socialized and modeled early, right? In childhood, right? It's marketed, right? Think McDonald's Happy Meal, right? Haagen-Dazs, I believe, has a flavor called chocolate therapy. So it is all around us, right? It's reinforced in music, on social media. And the truth of the matter is that when we eat in response to emotion, it does make us feel better. That's real. That's real. It's not all in your head. It leads to mood elevation. Let's talk a little bit about emotional eating and what it is not, because I did have someone in the audience refer to it as boredom eating, right? So boredom eating is eating in response to boredom, right? Your mood could be neutral. You're not necessarily stressed out or angry or frustrated. Eating is the event, right? It's different than overeating or hedonic eating. Think a phenomenon where you are eating something and you're kind of getting a partial fullness signal, but you're enjoying the experience of eating so much you blow right right past it because you like the flavor and the taste, right? Right? It's different than food rewarding. Think, I've been so good, I deserve that sweet treat, right? And it's also different than mindless eating, right? Think movie theater popcorn, right? You're distracted while you're eating. You're watching a television show and you look down and that bag is gone and you don't even remember going through that bag of food. It's also quite different than binge eating. Binge eating is a separate and very specific clinical phenomenon. It's a phenomenon oftentimes where you are eating oftentimes a large volume of food over a short period of time. And somewhere during that eating episode, you feel like you cannot stop yourself. You're almost dissociated, right? And you are going beyond fullness to the point sometimes of stomach distension or physical pain, right? Oftentimes in binge eating, to kind of differentiate, there are incredible feelings of guilt, shame, frustration that come along after you've gone beyond that point of physical kind of discomfort and fullness. Let's talk about the impact of emotion-based eating, right? Whether it's boredom eating, binge eating, food rewarding, in many situations, it's going to lead to excessive calorie intake. I mean, in one single emotional eating episode, you can kind of clock between 500 and 1,000 calories. And if you don't believe me, 10 Oreos, 550 calories, and that's easy to do, okay? Right? It oftentimes is correlated with excessive weight gain, obesity or overweight. It also oftentimes is correlated with many disordered eating patterns, and it is related to obesity-related comorbidities. Think hypertension, diabetes, high cholesterol, which ultimately affects a person's overall mortality level. So let's differentiate physical hunger from emotional hunger, right? Okay? And the kind of primary hallmark features that kind of distinguish physical hunger versus emotional hunger are these. When we're talking about physical hunger, oftentimes there are physical cues. You might get stomach growling, right? You might be thinking about food and considering options, right? Your energy might be a little low when you're actually having a physical hunger experience. And the hunger typically slowly grows over time. And typically with physical hunger, there may have been kind of a distance between the last time you ate, say, or three to 4 hours, right? Compared to emotional hunger. That stomach is quiet. You're not necessarily getting a hunger signal in the stomach. You might have specific cravings, right? You're not just considering food options. You might be thinking about something sweet or something with carbohydrates, right? And you also, notice that the hunger is actually something that is, kind of, it doesn't necessarily slowly build. It's actually coming on more immediately. And in those situations of emotion-based hunger, food feels like the best and only option in that moment. All right. The truth of the matter is, as I mentioned earlier, when we're eating foods like cookies or carbs, these foods do elevate mood, right? They lead to comfort. That's why it's sometimes referred to as comfort eating, right? The comfort we feel typically is associated with hormone rises, right? Things like serotonin and dopamine are increasing over time. Oftentimes, that they don't last very long, so you peak very early, right? And the more you continue to emotionally eat, you do not continue to get these base levels of serotonin and dopamine rising. So let's talk about common triggers, right? Because we talk about triggers of emotional eating and not so common triggers. I think traditionally when people come to me, they talk about stress, anxiety, they talk about sadness, they talk about feelings of anger or frustration sometimes. But not so common triggers might be environments, like work or social environments. They might include times of day. Think the afternoon lull at work, right? Situations, like presentations, right? Exams, right, might trigger these things. Relational conflicts is a big one, right? Movie and media, right? You might be watching a movie, a sad movie, that might actually trigger feelings of sadness and in turn trigger emotional eating. People, right? In-laws, right? Difficult relatives, right? As the holiday season is approaching, right? But also, difficult bosses, right? It can be things like that. An additional kind of less obvious trigger that I haven't included on this post is actually pain, right? Pain, migraines, those kinds of things oftentimes can be a less obvious trigger. So this is kind of a clear depiction of kind of the general pathway when I talk about raising awareness, right? In clients, right? You're having a really difficult moment. You might feel frustrated. You might feel anxious. And you say to yourself, I don't want to feel this way. Gosh, how do I change it? You go through your mental Rolodex of different options, and guess what's at the top of the list? Food, right? For many of us, right? It's been modeled, remember, right? And again, mood elevation does come. So that's typically what we're dealing with, okay? But what I encourage people to consider is this. When we're eating in response to emotion, food is not what we're seeking. We're seeking what food can do. And for many of us, it's these two things. It can comfort us, right? Lead to base levels of, kind of mood elevation, and or it can distract us, right? It can distract us from the thoughts that are coursing through our head, or sometimes the intensity of the emotion that we're feeling in the moment, right? And food does a good job at both, right? And that's why it's so difficult to manage these things, all right? So how do we fix it? Oftentimes that's a question, right? How do we eliminate this? How do we fix it? And my clinical response all the time when this question is presented in session is, we don't fix it. I mean, we're talking about dismantling decades and decades of programming that's reinforced, right? We manage it, right? We don't ever expect not to be triggered, right? But what do you do when you're triggered in these moments? Right? And this is a kind of structural kind of representation of how you manage it, right? So, remember the analogy I gave. You're having a difficult day, and you think to yourself, I don't want to feel this way. You go through your mental Rolodex of different pathways to change it. Remember, for many people, food is at the top of the list. My strong advice during interventional sessions is to not focus on removing food from the list, but always bump it down to number 3, at least number 3. But what it requires that we always attempt 1 or 2 non-food-centric pathways to get our needs met, right? Now, distraction is pretty simple, right? You can take a walk, you can change your environment, but comfort is a difficult kind of, abstract concept, right? If we talk about comfort as baseline increases in things like serotonin and dopamine, like what can do that, right? And I always tell my clients when we're going into this, nothing is going to scale to food. So let's be honest, right? Nothing's going to quite give you that dopamine and serotonin surge like a cookie. But what other things lead to comfort? Exercise? Okay, if you can do that during the course of the workday. Uh-huh.
Talking to a friend,
Socializing, social contact, perfect. Laughter, right? Listen to a funny podcast, right? Watch some reels if you can, right? Okay? Music. Has anyone ever heard a song that no matter how you feel, it gives you a little boost, right? Again, we're not trying to eliminate food from the list, but we're trying to slow down how automatically we go to food to get our needs met. Remember, our needs are comfort and distraction, right? And this takes practice, right? You don't automatically just get it. And I tell clients that this is a harm reduction technique, right? It doesn't necessarily mean that we will never eat in response to emotion, but our strategy is to slow down how fast we go to food, right? Our strategy is to minimize how far we go when we are eating in response to emotion, and also to minimize how often these situations are occurring. So what are kind of some strategies or kind of some techniques? What I've been describing for most of this lecture is really a concept called EEE, effective emotional eating. It's a harm reduction strategy that was developed by a psychologist named Linda Craighead. It really is raising first that general awareness, right? That food is not what we're seeking. It's a pathway to getting other needs met. It does kind of, focus and highlight on really skill development, right? Adapting other non-food centric pathways, right? And it also works on getting through the barriers, right, in the moment that make it difficult for us to actually go to these strategies, all right? I also kind of look at other techniques that are evidence-based like CBT or cognitive behavioral therapy, solution-focused therapy, and also kind of dialectical behavioral therapy. These strategies are really kind of hitting at the mood regulation kind of component, right? We're doing cognitive restructuring. We're helping people to manage distress, to not run away from feelings of anxiousness or low mood, but to find ways to essentially tolerate that distress without trying to run away from it, right? We're kind of working starting at the level of cognition and also emotion. And then there are some new innovative techniques, that are kind of AI or tech inspired, right? There is a program called Spiral Up by Dr. Mellon, and it's actually a program that is linked to an app that has a subscription, right? It's a behavioral modification app that kind of prompts you, right, in real time when you go on the app to engage in other adaptive coping strategies in the moment to really spiral up, she calls joy, but it's spiraling up comfort. It's providing other specific activities that you might engage in that are alternative to eating in response to emotion. All right? All right. Okay, I think I'm going backwards. Sorry, guys. All right, all right. So, in summary, if we're going to manage emotional eating effectively, we first have to raise awareness, right? Raise awareness about what food does, right? Raise awareness about common and non-common triggers to emotional eating, right? We have to understand and identify our triggers, right? And we also have to understand and identify and distinguish physical hunger, right, from emotional hunger, so we know what's happening in the moment. And then finally, we have to acknowledge, right, that comfort and distraction is truly what we're seeking. And then develop strategies and also engage in them in response to the emotion to get our needs met effectively. Thank you.
Our next presentation is Dr. Safa Osman, who's going to be talking about obesity in women across the lifespan.
So we're going to go over obesity in women. We're talking about the prevalence first. As 2023, 41.3% of women were suffering from obesity, BMI more than 30, and this indicates that 4 in 10 women affected by obesity. 12.6 women suffer from severe obesity, which is compared with men is 6.8%. Women aged, the peak age of obesity is age 40 to 59 years old, and that about 47.4% of women at this age affected by obesity, compared with the younger and older. While overall obesity prevalence has held relatively steady, the severe obesity is going up, and the most affected are women. We skip here. Rising maternal obesity. Obesity in pregnancy has become significant global health concern. The prevalence of obesity in pregnancy has more than tripled. From 5%, it went up to 16.3% between 2010 and 2019. When considering both overweight and obesity, the number go up from 21 to 44%, that between the same years. In the United States, pre-pregnancy obesity rates rose from 26% to 32% in 2022, and that's significantly after the pandemic. This rising trend of maternal obesity increased the risk of serious complications for women, for the mother and the baby at the same time during pregnancy, delivery, and long term. Maternal obesity elevates the risk of adverse outcome for the mother, child, including gestational diabetes, preeclampsia, cesarean section, fetal macrosomia, congenital anomalies, and long-term metabolic disorder. 50 to 70% of women with gestational diabetes develop type 2 diabetes in 5 to 10 years if preventive measure is not taken. Let us talk about the life transition in women. The main hormone responsible about all of this life transition is estrogen. When puberty, when estrogen rise, we have first cycle, fluctuation of estrogen result in monthly cycle, steady increase of estrogen during pregnancy, responsible for all the changes during pregnancy. The estrogen decline, we start going to premenopause, menopause, and this is where the sex hormone is going low. Women life transition create multiple high-risk windows for obesity. Let us learn about this a little bit. So the life transition in women, starting with puberty, we have significant hormonal shift rising of the estrogen, and that result in fat deposition in peripheral area, the hips, the thighs, and breast. Body composition start changing at this period of time, and the same time, we have some changes, which is decreased physical activity, change in the eating habits. We know that this is risk for the eating disorder as well, and psychological changes also. In pregnancy, that is intention stage of weight gain, actually. This is result in some physiological metabolic changes. Excessive gestational weight gain increase obesity risk. Postpartum period associated with sleep deprivation, decreased physical activity, hormonal fluctuation secondary to breastfeeding, and lifestyle changes that make weight retention easy and common. Many women at this stage, they do not go back to their pre-pregnancy weight, and that's a major problem. In premenopause and menopause, we have decline in the estrogen level. What that does, estrogen is fat storage, actually. And when we don't have it, that means the shift of the fat will happen from the peripheral area to the abdominal area, and that's result in center obesity or visceral obesity. The metabolic rate at this period of time is slow down, and that because of the decline in the muscle mass. Women during this transition gain 5 to 10 pounds without changing diet or activity. Basically 1.5 pound every year between premenopause and menopause period. This hormonal change make weight loss more challenging. Why obesity is more common in women than men? First of all, hormonal change and biological differences, pregnancy and reproductive factors, lower basal metabolic rate, psychosocial and behavior factor, and PCOS. PCOS only affect about 10% of the women. Let us talk about the hormonal change. Estrogen promotes fat storage, especially in the subcutaneous area, hip, thighs, breast. After the decline in the estrogen, we have shift of the fat from the peripheral area to central area. And this is showing that the pear shape and the apple shape, which increase the cardiometabolic risk. Pregnancy and weight gain. Pregnancy lead to weight gain and increase insulin resistance. During pregnancy, we have physiologic insulin resistant adaptation to the pregnancy because they want to make sure there is enough glucose going to the fetus. And that is a problem because these women, when they come to get pregnant and they are overweight and obese, they have a problem with gestational diabetes. They end with because there is adaptation of insulin resistance during pregnancy. Multiple pregnancies and inadequate postpartum weight loss increase long-term obesity risk. Studies show that postpartum weight retention is the strong predictor of long-term obesity. Always when we take weight history from women, you find the pregnancy is always the blame. The postpartum period is critical window for weight management. Close postpartum weight monitoring is essential, and it is preventive strategy to reduce obesity, diabetes, cardiovascular disease in women. Without guidance, many women retain about 5 to 10 pounds after each pregnancy, increasing lifetime risk of obesity and metabolic disorder. Treatment of obesity in pregnancy, prevention is the key always. Preconception counseling and weight management before pregnancy are the key. During pregnancy, preventing excessive weight gain, optimizing nutrition, and maintaining safe physical activity. Anti-obesity medication, all of them contraindicated. We don't want them to lose weight, right? During pregnancy, instead of that, the focus will be on the maternal fetal health, postpartum weight management, and close monitoring to prevent the long-term obesity. Let us talk about the low basal metabolic rate. Muscle tissue burn more than fat. That is science, basic. Women have higher fat percentage than muscle, and that is one of the problems. That lowers the basal metabolic rate. Women tend to have smaller bodies compared with men. BMR increase when the body mass is bigger or higher because we need more energy for basic function. Regarding the hormonal differences, estrogen and progesterone affect metabolism and fat storage. Testosterone cause muscle build or increase the muscle mass. In men, the basal metabolic rate 5 to 10% higher than women. It doesn't matter, the same age, the same weight, but the basal metabolic rate is higher in men because of the higher muscle mass. In women, are more prone to weight gain with the same calorie intake as men if activity and diet is the same. The psychosocial factors, women are more prone to sleep disturbance. We know that there is sleep disturbance during pregnancy. There is sleep disturbance during menopause because of the hot flashes and so on. Emotional eating, tendency to eat in response to emotion is also another problem. Let us talk about PCOS. PCOS is one of the complex and multi-endocrine problem. We have genetic factor, hormonal factor, environmental factor. The Endocrine Society report that about 10% of women affected by PCOS is higher in women with obesity or overweight, women with insulin resistant, family history of PCOS is higher risk, and also certain ethnic groups, South Asian, for some reason, they have higher rate of PCOS and severe form. Not all women with PCOS are overweight and have obesity. That's important. Only 35 to 50% of women, they can be normal BMI and they have PCOS. 50 to 65% they have overweight and obesity. 60 to 80% they have insulin resistant, and the main reason behind that, they have intrinsic genetic insulin signaling. They're born with insulin resistant, and that's one of the problems. That's the best physiology is a little bit complicated. I will try to make it simple, which they have insulin resistant genetically. They're born with it, and that's one of the problems. Insulin resistant, when we have it, then the pancreas produce more insulin. The insulin, it has direct effect on the ovary, and that stimulates the thick of the ovary to produce androgen. The other problem with the insulin, it does have direct effect on the liver to reduce the sex hormone binding globulin. And the sex hormone binding globulin usually combined with the testosterone to make it inactive. But we don't have the globulin because it's inhibited by the insulin. What we have here, testosterone go up. Okay, testosterone go up, and that result in hirsutism, and cause acne and other problem. The other way also, the pulse of the increased frequency of the pulse of gonadotropin releasing hormone, and that favor LH more than FSH. LH will have the same effect as the insulin increase the androgens. That's basically what's happening, but the genetic defect they have on the insulin metabolism, that's the main problem. Weight gain creates dangerous vicious cycle for people with PCOS. Weight gain worsen insulin resistance and result in higher insulin level that stimulate the ovary to produce more androgen, and this lead to irregular period, infertility, hirsutism, acne, metabolic syndrome, and higher risk of diabetes. Weight management can break this cycle, and only 5 to 10% weight loss can be helpful. Let us talk about the treatment. Basically, we start with lifestyle therapy, but the most important, we go with nutrition, physical activity, behavior, but treatment intervention, which can be pharmacological or surgical option. Pharmacological therapy, we have the metformin, and that improves the insulin sensitivity. All patients with PCOS, they need to be on metformin. Anti-obesity medication indicated when BMI more than 30 and more than 27 plus comorbidity. GLP-1 actually is very effective in this patient, and the recent data from 2024-2025 showing that the GLP-1, it does help with the insulin resistance, and it helps with weight reduction, and is very effective in this patient. Bariatric surgery for severe cases, BMI more than 40 and more than 35 plus comorbidity. This bariatric surgery actually is highly effective in PCOS with severe obesity for weight loss and improve the ovulation, fertility, and metabolic health. Menopause. I'm sorry. Okay. Menopause defined as 12 months, no period, and average age is 51 in the United States. The transition actually begins with premenopause irregular cycle, and because of the hormonal change and decline in the estrogen. What's happening here? Estrogen decline, the peripheral fat shift from the peripheral to the visceral area, and this results in insulin resistance and increased cardiometabolic risk. And that is a major problem here, the shift of the fat. The set point definitely will go up because of this hormonal change. Decline estrogen result in fat redistribution and from the subcutaneous. I think that is the same thing I mentioned, so nothing major. But in addition to that, we have decline in muscle mass, which one of the problem at this age because it reduces the basal metabolic rate. Lifestyle and aging, reduce physical activity, sleep disturbance, and increase and emotional eating will be a problem. This is very important, the body composition in women. Menopause lead to increased fat mass, especially visceral fat, and a decrease in the lean body mass, which you can detect that by BMI. So having these people assessment with body composition, such as DEXA scan or in-body, that will be better option because it gives you better assessment for what is going on exactly. There is something called sarcopenic obesity, excess fat and loss of muscle mass, which is very common in postmenopausal women. It leads to loss of strength, lack of mobility, and disability as well. Tracking the lean mass fat percentage, visceral fat in postmenopausal women is crucial. The goal is to support fat loss and maintain the muscle mass. That is just the management strategy. You start with lifestyle therapy, that is the main thing. And then we have anti-obesity medication, the GLP-1, it works great in this patient, improving their cardiometabolic risk and weight loss at the same time. HRT, hormone replacement, is not for weight loss, but it mainly help with the hot flashes, with the sleep, and it can help on the shift of the fat if they use it early. Bariatric surgery indicated for the same indication that, in this patient. This is just a recent study going on postmenopausal women and GLP-1. The one presented in the Indo 2025, they tried tirzepatide plus HRT together. The weight loss is fabulous, 35% total body weight loss in this patient, and also their cardiometabolic and waist circumference is significantly improved. They did a study on low dose of semaglutide in postmenopausal women. They have great response also. Most of them, they lost 5% of their total body weight, which is great. The high dose, they didn't do this in women, but 1,400 was participant, 74% women, and age 47 and older. And they have wonderful response with this as well. About more than 20% they lost total body weight. So yes, GLP-1, it does work and very effective in this patient. My summary. So the rising trend of maternal obesity increases the risk of serious complication. The postpartum weight loss isn't cosmetic. It is vital to prevent the chronic disease, restoring metabolic health, and protecting the future pregnancy and prevent long-term obesity. PCOS is complex endocrine problem, and we have dysregulated hypothalamic pituitary ovarian signaling, and also it associated with genetic transition, which is have defect on the insulin insulin receptors. Menopausal weight gain is driven by hormonal shift and loss of muscle and lifestyle changes. The hallmark is the shift of the fat, and this results in increased cardiometabolic risk and increase the risk of cancer. Body composition is essential to be done in postmenopausal women to give you exact break of what is going on and increase of the visceral fat, which cannot be detected by the standard BMI. That's it. That's all I have. Thank you.
Hello, everybody. Thank you for attending, and thank you for the organizers for asking me to present today. We've had a lot of wonderful speakers, and I've learned a lot that I can take back to my practice. I know we're coming up on 12 o'clock, so I'll try to make this quick and succinct to leave time for our discussion and get you guys out of here to get your lunch and do your weekend chores. So my talk is more about the impacts of weight loss. So we all can agree that obesity has a lot of negative consequences, but what happens if we reverse the obesity and we get people to lose weight? Is there evidence to support that health and life expectancy improve? So I'm going to kind of tackle some of these here and show you some slides to that effect. So again, I also do not have any disclosures. No one is offering me to do any drug lunches, so that's an easy one. So some simple slides that I think a lot of you have probably seen throughout the course of the day today. But there's a lot of organizations and groups that kind of really highlight the importance of obesity as a chronic medical condition, not only here in the United States, but globally. So even the World Health Organization in 2021 showed that there was about 4 million deaths that were directly linked to obesity from the consequences of cardiovascular disease, cancer, neurological disease. You can read these. And the problem actually is starting earlier and earlier. It's not just adults that are becoming obese. This is starting in adolescence and in childhood. And these children are being put at a big disadvantage because the obesity in their development leads into the adulthood prevalence of obesity and the early onset of type 2 diabetes and cardiovascular disease. We've also seen a lot of our talks or presenters today talk about the mental health aspects of obesity, and of course there are psychological consequences. So kids are being stigmatized, both having an interpersonal battle with that, and the external battle being at school. Either we talked about like the desk sizes, things that we don't necessarily think about, but it has an impact on school performance, quality of life. They're missing school either because of depression, anxiety, or because, as we'll see later on, some of the health consequences that are associated with it as well too, maybe hospitalizations. Obesity used to be thought of the rich man's disease, right? No different than gout that we thought about in the past, but it's becoming more and more a lower socioeconomic and in developing countries as well too. That's a more complex issue, but it's not just the United States problem. So just wanted to highlight that. Both the CDC and the NIH, other large organizations, have also highlighted the importance and the impact that obesity is having on adults and in children, and the cost to the American healthcare system is immense. We're talking about $180 billion a year by current estimates. So imagine what that money could be used for in terms of other aspects of healthcare. And in fact, it's gotten to the point that we all think that, you know, we're the best shape in our lives when we're about 20 years old, 18-year-olds, 25-year-olds. We're seeing about 40% of young Americans don't even qualify for basic training or military preparedness. So it's impacting some of our, not just our health, but if you think about security benefits as well too. The NIH also, lists it about a third, and we heard even higher numbers with some of our other presenters, that a third of all adults and about a fifth of all children are classified as obese, and those rates are increasing, and across all ethnic groups, socioeconomic groups. So it's not just a poor person's problem or a Hispanic problem. It's across the board. Now, some groups are a little more disadvantaged than others, and it's beyond the scope of this lecture, but just highlighting that we really all have to be focusing on this. So a lot of us used a similar slide here showing the impact that obesity can have on the entire body. It's not just on your bones or just the cardiovascular health. Everything from pulmonary disease that I'll talk a little bit about to your immune status, mental health, renal disease, cardiovascular disease, and of course, reproductive health and malignancies. Mechanism of action, I think a lot of the other presenters did a very good job of describing insulin resistance and the hormonal impacts that the fat tissue can have on the body, and this is how it's mitigating. It's not just a mass issue, it's a communication issue. There's a lot of cytokines and hormones and biomarkers that are being fed into the fat tissue and then pushing it outwards as well too, and having inflammatory responses throughout the body that lead to some of these conditions that we've talked about. But even the mechanical stress of being overweight, I found this kind of interesting when we're talking about lower extremity arthritis. 1 extra pound of weight adds 4 times the pressure on our knees with each step. So think about 10 pounds weight gain could be 40 pounds on your knees. So imagine carrying a 40-pound bag around all the time, strapped to your knees. So that's a big, big burden on the body. So this slide is kind of an introduction of that, and it shows kind of the importance of rising BMIs with the relative risk of developing disease. So we have 4 different things that this was looking at. We can see men and women are separated, and we're seeing similar correlations. But the things they looked at was the red line in diabetes, the dotted lines were hypertension and gallbladder disease, and the faded yellow line, I believe, is a coronary artery disease. And you can see there's definitely a correlation here. As weight goes up, the risk of developing these diseases down the road increases. The 2 interesting things that I took out of this slide is look at the rate of increase for diabetes. It is far higher than anything else. And we know that diabetes is rising in the United States, and it's a big thing that weight loss can be helpful with, whether it's bariatric surgery or medicine or a dietary approach or a combination of both. So, but even more importantly, when I looked at the numbers, if you look on the bottom, look at those BMIs. They're not 40, they're not 50. Even at 25, we're seeing a rapid increase in the relative risk of developing diabetes down the road. So it goes to show that early intervention is key. That doesn't mean that you will develop it, but being at a higher BMI puts you at a bigger disadvantage. So we really want to start moving these further down the graph, and it's never too early to start. And that's the highlight about in adolescence as well too, and in our 20s and 30s when we're like, I'm gaining a lot of muscle mass. Are you really gaining muscle mass? We don't really have a good way of judging that right now because BMI is what we're using, and there's probably better measures, but just highlighting that. Okay, so I'm going to talk, I don't have time obviously to talk about every of the 230, I believe, comorbidities and conditions that have been linked to obesity, but I want to highlight a couple that we can kind of use as an example of why losing weight is important. So the first thing I'll talk a little bit is about our metabolic health, right? We see Mr. Apple and Mrs. Pear sitting there, and that's how we stereotypically gain weight. So I wanted to focus a little bit on diabetes and cholesterol issues here. We know that about 80% of our type 2 diabetics have been attributed to being linked as obese. So there's definitely a correlation there. And that metabolic process is brought about by a lot of self-imposed lifestyle issues, some genetic issues, and maybe some comorbidities. But basically, insulin resistance is a big driving force here, and I think Dr. Osmond did a very good job of explaining that. So I'll leave that as it is. But the effects of the accumulation of fatty acids and driving cholesterol issues are up, and we know the direct correlation between elevated cholesterols and cardiovascular health is there. So we know that association. So what happens if we aim to have people either that are pre-diabetic or diabetic to lose weight? Will that have an impact on their health? So this was the Diabetic Prevention Program study, and what it took was patients that were not already diabetic but maybe were at risk for becoming diabetic, and they wanted to see if they lost weight, would that have an impact down the road in them progressing. And what they did find is a negative correlation correlation here. So you can see, does that show up? No, it doesn't. Okay, so we can see they're starting off at the 0 mark and losing weight, and as they're losing weight, the incidence of developing diabetes is going down in a nice pattern. So what they came up with was that with every kilogram of weight loss, you had a 16% reduction in developing type 2 diabetes. So again, this is important because a lot of times patients might be 50 pounds or 80 pounds overweight, and we think it's an insurmountable task that, oh my God, we need to get them down to a normal BMI of 25 and that's the only time that they'll be healthy. And this clearly shows us that's not the case. It's a process, it's a journey, and every step counts. And that first step is sometimes the most important one. So I think this can be encouraging not only to the clinicians here in the room, but to our patients as well too. You can have an immediate impact on your health of just starting losing 2 or 3 pounds, 5 pounds, 10 pounds. Similarly, we saw in another trial that I was able to find called the DIRECT trial, they took actual diabetic patients and they followed them for 2 years, and they put them in a real-world primary care study where they had an integrated medical program where they were being given a low-calorie total diet replacement program for up to 20 weeks, and then slowly afterwards they would reintroduce normal food that they were allowed to self-regulate with, and they monitored their weights and they monitored their diabetic control. And what they found was, 24. We had an intervention group and a control group, right? So in the intervention group, a quarter of them were able to lose 15 kilograms or more, and that was pretty astounding. But the big thing here was that after losing the weight, almost half of them had remission of their type 2 diabetes, and they were off all medications. And up to 2 years, they saw that was maintained at about 36%. So there was some really good longitudinal effects of remission with people losing the weight and maintaining the weight. And of course, they found that there was a higher correlation. The more the weight loss you had, the better goals you had in terms of remission and staying in remission. So we're seeing some evidence that losing the weight actually reverses. Similarly, I'm going to talk a little bit about cardiovascular health. We know that there's a strong component of metabolic syndrome and obesity with cardiovascular health. There's a 3-fold increase of developing strokes and heart disease for our obese patients. But it goes beyond the arterial side. The atherosclerosis risk in communities study estimated that 1 in 5 patients with obesity also had atrial fibrillation attributed to that disease, so arrhythmias as well. Framingham study, a lot of us are familiar with. We probably started learning about it in medical school or in our training because it's been going on forever. But they saw a 2-fold increase in heart failure patients that also had obesity. So we're seeing all aspects of cardiovascular health being affected by weight. And we feel that a lot of this is being driven by the inflammatory markers, things like tumor necrosis factor and interleukin-6, that are some of the driving forces, and of course, metabolic syndrome and insulin resistance. One thing that insulin resistance and hyperinsulinemia, sorry, it's as hard to say as Herobopolis, but another thing that has a direct impact on cardiovascular health is that it stimulates the sympathetic nervous system, and that has an impact on the renal system where it encourages more salt absorption. Increase salt, retain more fluid, higher volumes, stretching the tissues, you get the idea, right? So in this case, it is it is physics. And of course we know that this can ultimately lead to things like left ventricular hypertrophy, and that also has been linked to sudden death, death after an MI, ventricular arrhythmias, and heart failure. So what if we lose some weight? Can we have a positive impact? And the answer is yes. In this study, they looked at patients, and again on the bottom you'll see how much weight they lost or gained. So they looked at it both ways. So the middle, and I apologize, I don't have a pointer here unless this one is working. Yep, there it is. Okay, it doesn't really show, but that's our baseline. So when patients gained weight, we can see their systolic blood pressures have gone up. Diastolic wasn't really a big issue here when they gained weight at up to 7 kilos. But when they lost weight the other way, both systolic and diastolic went down. So this is very promising. And look, we had a positive impact, again, with only 2.5 kilo weight loss, 5-6 pound weight loss. So you don't have to lose 30 pounds to have a positive impact on your cardiovascular health, at least initially. I wasn't tasked with talking about GLP-1s, but I'm asked about them 16,000 times a day, so I thought I'd at least have one slide on it, and it doesn't have to do with insurance. But this study on tirzepatide showed obviously that when you give patients tirzepatide compared to control, they lose weight, and it's a dose-dependent matter. The higher the dose, the more the weight loss. That's what the top slide shows. The bottom slide almost mirrors the same thing, but instead of measuring weight, they looked at blood pressure. So again, another way that we can see that having weight loss has a direct impact on the physiology of our patients and decreasing their risk of hypertension and the consequences of that. Okay, obstructive sleep apnea. This is one thing that I always tell my colleagues. I never knew how much OSA was out there coming out of residency. I had heard about it, but once I came into private practice and primary care, I was astounded, and it came in all shapes and sizes, including myself. So I have sleep apnea, and I thank Dr. Stein for his CPAP orders. So you don't have to necessarily be obese to have sleep apnea, but there is a strong correlation. So here's some statistics. I don't want to bore you with them, but basically it's on the rise, and we think it's on the rise also because obesity is on the rise. And the more weight that's gained, the higher chance you have of having sleep apnea. If you look at this second, the one that says study number 2, 11% of males and 3% of females who had a BMI of less than 25 had sleep apnea. And then as the BMI goes up into the overweight category, those numbers jump up to 21 and 9. And when you get to the obese category, you're looking at 63% and 22%. So there's a rapid increase of obesity related obstructive sleep apnea. So much that I think one of our GLP-1s, tirzepatide, is approved for sleep apnea. And I think it's because of this. It doesn't, not that I know, does anything physiologically to the pathways here other than decreasing the weight. That puts less burden on the chest and probably shrinking the anatomy of the palate and the neck size, which also decreases the obstruction in the airway. So a study was looked at that to see, okay, if we get to sleep apnea, can we reverse it by losing weight? And they looked at surgery, drugs, and lifestyle. And again, the pattern is the same. You can get there by gaining weight, you can get out of it by losing weight. And this is showing percentage of weight loss. I want to talk a little bit about another thing that's often kind of missed, the correlation between obesity and asthma. We have seen an increase in obesity, as we know, over the years, but we have seen a parallel increase in asthma over the years. And this slide, I think, goes back to 1980, 1975 or so. So there's almost a direct correlation, a direct association. We don't know if it's directly linked, but when you look at asthmatics and you break this, what this slide shows is a total asthmatics in male and female. As BMI increases, the prevalence of asthma increases as well too, and you see it at a bigger impact in women over men. The pathophysiology here is, again, we think that's inflammatory markers, including interleukin-6 again, because we know that asthmatics with these high levels have poor control of their asthma. And we also know that the diets that are higher in sugar and saturated fats and lower in fiber also have been increased with increasing the risk of respiratory symptoms. And there's also a physical component by just having more adipose tissue around the chest wall and the abdomen. It inhibits the mechanics of breathing, so you decrease your functional residual capacity, everything's compressed, and it can also increase airway reactivity leading to asthma attacks. They've actually seen this in animal studies where high insulin levels also create this kind of bronchoconstriction. So again, this high insulin resistance pathway that we've been talking about is a common thread that even can be seen in asthmatics. So if we have asthmatics losing weight, what happens? There's positives and negatives. So we talk about these inflammatory markers that can be decreased from interleukin-6 to leptins and adipose tissue inflammatory markers. Lung function usually improves. You get a decrease in airway hyper-responsiveness, and clinically, they just feel better. So they're reporting to you that their quality of life gets better. Okay, reproductive health affecting both men and women. Infertility is another growing thing that we are noticing that with obesity is an issue. And again, it can start as early in childhood. We know that obesity in childhood has been linked to abnormalities of the menstrual cycle, and that sometimes can lead to things like PCOS or other infertility issues. We have also seen that in studies that spontaneous pregnancy rates and the time to get pregnant increases with obesity. In this study, they showed that a 5 kilogram increase in weight from the woman's baseline weight when they were 18 years old was associated with a 5% increase in their time needed to get pregnant. So the more weight they're gaining, the longer it might take them to get pregnant. And of course, we know that there's maternal and perinatal complications from gestational hypertension and diabetes, preeclampsia, and large birth weights. There's sexual dysfunction that's reported. Some of it is psychological, some of it is physical, like erectile dysfunction for men. We had a very nice talk about PCOS, so I will spare you my take on it. But we also have fibroids, endometriosis, and abnormal uterine bleeding. So we've seen that in different categories of the organ systems and overall health, losing weight is important. But I guess the question is, how much weight do you need to lose? And I found this a very nice slide, and it broke it down into different things from metabolic to orthopedic to hepatobiliary. And basically, you can start seeing a really good movement in the right direction with even a 2.5% weight loss. And sometimes it just gets maximized at a certain level. There's only so much the weight can do, but for a lot of these things, there is a weight loss dependent component. The more weight loss you have, the better the outcomes. So again, encouragement for us all that getting those first steps going and showing our patients that let's work on 10 pounds, right? Let's work on 5 pounds, and let's keep the longitudinal goal there too. But let's not get discouraged if you plateau or if you fall back a couple pounds. Let's just keep the ball moving forward. Let's keep working at 2 to 5 pounds each time we're seeing you. So putting this all together, looking at longevity, does this have an impact, right? So we reverse the course, but does that improve our longevity? And this is an important question, I think, because the statistic that I saw in 2022, obesity surpassed the preventable cause of death over smoking. So generation before, we were telling people to quit smoking. It's the best thing you can not do to improve your overall health. And now we're replacing smoking with obesity almost in a preventable sense. And we have a big part to play in this. So I think that's why it's important. So what this graph shows is there's 2 J-shaped lines, if you wish. The top one is men, and the bottom one is women, because women are better than men, so they live longer and they take better care of themselves. But what I was trying to highlight here in the green box and in the orange box is if we look at the BMI between 20 and 30, that's kind of a sweet spot that most people that are in that 20 to 30, their longevity doesn't change all that much. Once you start getting into the orange range, you can see that the deaths per 1,000 in this way start to shoot up. So the higher your BMI, the more likely you are to not live as long. And conversely, the same thing if your BMI is too low. And those are patients who might have eating disorders or might be having cancer and losing weight. So it looked at everyone. So basically, if your BMI is between 30 and 35, you can estimate that you're losing about 3 to 4 years. You can cut 3 to 4 years off your life expectancy. And when it gets up to 40 to 45, you can lose potentially up to 10 years of life expectancy. So it is significant. So is it ever too late to start losing weight was one of the questions that was posed to me. It's like, well, what if yeah, this is the last slide. Perfect timing, right? Okay. And yes, this study showed that losing weight had a big impact on both, not only life expectancy, which is on the side over here, but also developing chronic diseases. So that's my presentation. Thank you, everybody.
All right, I'll make it quick. So I just want to talk about long-term outcomes and a little bit about redefining success in obesity treatment. Again, I have no disclosures. So this kind of brings together a lot of the talks I think that we've already heard. And so we want to talk about what are our goals in obesity treatment and what are we really looking for beyond just the number on the scale. So this is kind of just a proposed success model. So the first layer we're looking at is, in general, reducing harm, like risk reduction. Dr. C mentioned all of these different areas that obesity can affect. So we want to look at how are those numbers changing. And then moving into the second tier, how is that affecting the different disease states that those numbers might reflect. And then we want to look at hard outcomes in terms of reduced coronary events, reduced morbidity, mortality, and then, of course, maintaining health and preventing relapse, as this is a chronic condition. So just to look at some of the data, I know this is a really busy slide, but I just want to highlight a couple of these landmark trials that have come out recently. So the first two are the SURMOUNT and SURMOUNT OSA. These were studies done on tirzepatide. So this is looking at how medicine affects weight loss and outcomes. So in the first trial, it was done on tirzepatide, and they showed at about a year and a half into therapy, on average, patients had lost about 15 to 20% of their starting body weight, and that was maintained even a year and a half out. In the OSA trial, they were looking specifically at metrics of improvement in sleep apnea. So they saw about the same amount of weight loss, but a significant reduction in the apnea-hypopnea index, which is the way we measure how severe someone's sleep apnea is. And it was reduced by 25 to 30 events per hour. The next trial is the SELECT trial. This is a very important trial that showed the efficacy of semaglutide or Wegovy. And this was done, I think, 3 years long-term into the study. They showed up to 20% reduction in the relative risk for cardiovascular disease. And so now Wegovy is approved as a treatment for people who have cardiovascular disease, aside from weight loss. And Zepbound, or tirzepatide, is approved for sleep apnea treatment outside of weight loss. So it's just to show that these medications do have a lot of long-term benefits. The newest trial, which I'll mention on the bottom, is the ESSENCE trial, which showed reduction in liver disease, specifically looking at metabolically associated steatohepatitis, or MASH. And they showed 62.9% resolution versus 34% in placebo, and significant improvement in liver fibrosis. So this is, in GI, an exciting topic to show that these therapies are improving many metabolic conditions. So in practice, if we look at what this looks like long term, just kind of taking all these things together. So we definitely see the benefits long term of these therapies. With medication, we see the clinically meaningful weight loss, 15 to 22%. We see improvements in the A1C, the blood pressure, liver function. We see that hard outcome improvement in major coronary events, such as heart attack, stroke, and arterial disease. We see these liver benefits. So there's a lot of these good things, but there are some limitations with medication. Sometimes in one study they showed discontinuation rates up to 50%. That was for multiple reasons. Some of it was side effects, some of it was cost, some of it was availability. We do know, as Dr. Usman mentioned in the discussion panel, that you can regain weight if there is discontinuation of the drugs. There are issues with cost, and then of course tolerance in terms of GI side effects. And then again, as this is a chronic disease, this needs chronic management. So just briefly to look at surgery, and we'll look at endoscopy. I know these topics have been mentioned, but surgery, if it hasn't been said already, is the most effective weight loss tool we have. It's also the most durable weight loss tool, meaning patients who have had surgery are more likely to keep their weight off as opposed to any other modality that we have. Some of that is just based on the data we have, because surgery's been around much longer. but it is the case right now. We also see metabolic remission. Dr. Salome mentioned diabetes remission in all three of the surgical modalities, up to 60% even at 5 years in one study. And then we also see those hard outcomes in terms of benefit in cardiovascular disease and decreased mortality. There can sometimes be weight regain, again, as was mentioned, sometimes up to 15 or 20%, but that's 10 years out. So if you kind of zoom out and look at how effective it is and how durable it is, it's a really powerful therapy we have. Briefly, there weren't as many studies on endoscopic intervention. A lot of them were just looking at the total body weight loss. There was one I looked at on ESGs, which showed maintenance of the weight loss even up to 2 years. And some of these studies, as Dr. Huck mentioned, were also combining medication and endoscopy and looking at how effective those were long-term. But we do see long-term benefits with that as well, again, especially when combined with medical therapy. So if we just compare these three modalities, we see that in the initial year with medicine, it's again 10 to 20% total weight loss. With endoscopy, about the same. With surgery, it's more like 25 to 35 or more, depending on the procedure that's done. With medication, the durability we could classify right now as moderate. We just don't have a lot of long-term trials. With endoscopy, it's pretty good, but again, we're limited just in the duration. And with surgery, no, it's very good. We definitely know about the decreasing cardiovascular disease outcomes with medicine. Again, the SELECT trial was a good example of that. And then, of course, with surgery as well, with decreased mortality. So again, I know Dr. David talked a lot about what happens if we combine these therapies. And again, this is really the future. So we see that with endoscopy and anti-obesity medication, patients had much higher weight loss overall compared to if they were just using endoscopy alone. We had some slides earlier about the effect and the patient cases that Dr. David mentioned of how effective medication and surgery combined can be, and then medication, surgery, and endoscopy. So really, this is the future, that we're going to be using all of these modalities together to treat this condition.
I'm going to be tackling the topic of emerging technologies in obesity care. And I don't have any disclosures, although my disclosure is that I'm not a technology expert. So I'm just going to give you a good maybe overview of this with some of the exciting things coming or happening. So obviously there is, as we've heard, prevalence of obesity is big, it's an epidemic. And the problem with the current model is patients don't really get a lot of structured follow-up after the initial counseling visit. That's one of the issues that we see. So the traditional models are limited by access and by scalability. And they often fail because of the fragmented follow-up and the limited personalization. So the emerging technologies with devices, AI, and so on, does offer new opportunities to try to bridge that gap and allow these personalization. So when we talk about digital health, of course, we have to talk about telemedicine, right? And telemedicine has really expanded quite a bit during the COVID pandemic. And I think we're using it quite a bit in obesity medicine, and it has allowed that access, which is for some patients who face geographic limitations and barriers, rural areas, difficulty to access healthcare providers, maybe logistical reasons, their job or family, etc., socioeconomic impact. Telemedicine has allowed them access to these specialists. And when we look at data, there's been studies looking at telemedicine versus conventional treatment in obesity care. We know that if you're providing nutritional counseling and psychological support through telemedicine, you are achieving at least equal outcomes, maybe even better outcomes sometimes, as compared to traditional models. And clearly, the Academy of Nutrition and Dietetics the Obesity Medicine, Obesity Society, they recommend telemedicine. And I know in our practice we use it all the time. Our dietitians, our psychologists, everybody in our practice, we all use it quite a bit. So you have to integrate it as a way of to provide obesity care. Mobile health, or mHealth, is defined as the use of mobile and wireless technology to support the achievement of health objectives in general. And so when we talk about obesity specifically, it's using smartphones, tablets, wearable devices, and other wireless tools to achieve the goal of weight loss. And even with public health messaging, using apps, using SMS to spread health awareness is part of the mobile health. So let's talk a little bit about some of these devices, and I'll be a bit brief on those. But wearable activity trackers, right? Fitbit, what you have with your iPhone or Android phone, tracking your steps and what have you. So how effective are they? Well, they are effective, but the magnitude of the effect is limited, is modest. So there's been studies on that, randomized trials and meta-analysis, and they show some weight loss, but not drastic, 1 to 2 kilos in 3 to 12 months. So not a great weight loss in a sense if you just focus on those alone. To get the best outcomes, you really need to add goal setting, tailored feedback, and self-monitoring of both physical activity and certainly diet. So that's going to be really critical to achieve the best outcomes. Digital scales, right? So these are popular, smart scales, being able to kind of weigh yourself and record the numbers over time. It's helpful. It allows for integration. It allows to send data to clinicians, to digital platforms, etc. And looking at those digital scales and looking at studies, looking at daily weighing using these scales actually is quite helpful. And patients do better when they weigh themselves daily with these scales as compared to less frequent weigh-ins or no weigh-ins. So this is quite helpful. But again, the results are somewhat limited, and if you don't combine them with a bigger intervention, it's not going to be very effective. How about CGMs? You've all heard of continuous glucose monitors. That's definitely a lot of interest in this. What that is using these devices that are applied to the skin. It has a microfilament that goes under the skin and measures interstitial glucose continuously. So you can look at your glucose numbers on your smartphone, and you know what your blood sugars are doing in a continuous fashion. You can set alarms if the blood sugars go up, too high or too low, etc. And a lot of interest in this because you are monitoring the glucose response real time to meals, to stress, to activity, to sleep, etc. And theoretically, if you're using it, obviously not if you're using it in non-diabetic patients for weight loss sort of goal, it's going to give you this immediate biofeedback. So you could maybe alter your meals to not to have this glucose spike, and so indirectly not to have the insulin spike, which is probably leading to some weight gain. So you're going to have that biofeedback, and you can potentially tailor your diet and as far as what you're eating, maybe how much carbohydrate you're consuming, and what type of carbohydrates, etc. So again, a lot of interest in this and using it in non-diabetic patients. And then you look at the data on this, and there's been a few studies on that, including randomized controlled trials. It does show favorable effect on glycemic control in both diabetics and non-diabetics. But when you look at the effect of using these for weight loss, the weight loss hasn't really been statistically significant. So really, we have not seen weight loss from these as much as we kind of hope. But there's a lot of interest. Now you can buy these over the counter. They don't require a prescription anymore. So a lot of interest in using them. And there's a lot of ongoing studies, big-scale studies looking at this. So hopefully more to come. It's kind of exciting, but we haven't seen quite the results that we hope yet. There are a lot of digital platforms out there online, sort of various different websites and using different sort of FDA-approved interventions to achieve weight loss. These are things people sign up for, their memberships, and they get integrated through, sometimes integrated in big healthcare systems, but also approved by insurance companies trying to get you approved for these memberships, but also you'll get various digital scales and various wearable devices to achieve weight loss. So, and you look at these platforms, and you look at some of the data on that, the weight loss seems to be better compared to other interventions, but again, it is quite modest. Again, the data on these is okay, but not great. Some of the effects tend to be sustained up to a year. However, the magnitude of the effect from using these apps tends to sort of decrease over time, and people sort of drop off and stop using them. So the long-term, maintenance, adhering to these and maintaining usage of these apps is somewhat limited over time. So the drop rates are higher. So to improve the rates of to reduce, dropouts, trying to make it more personalized, adding interactive features is going to be key. And I think this is kind of where AI it becomes interesting. And a lot of these apps now incorporate AI. I think Dr. Coleman mentioned one of the apps using it for psychological support. So these AI chatbots, these AI sort of conversational agents are being used to provide personalized dietary intervention, behavioral nudges, psychological support, etc. And I think that's going to be more interesting. Looking at some of the studies, one of these AI-powered platforms showed at 6 months a fairly good weight loss of 14%, which is pretty good. Again, short term, but it may be interesting to see how these get, what kind of results you get over time. What's interesting also with these AI models, they seem to do better as far as predicting results of interventions. So if you look at AI models and how a certain intervention would work, they do better at predicting the outcomes of various interventions, medications, etc. So maybe that would allow for better or earlier interventions over time. One thing that's interesting is sort of the reinforced learning of these algorithms. So this is basically the algorithm learning from the feedback it's getting from the environment and modifying the recommendation over time. So if you look at, for instance, obesity, these systems are monitoring digital data, like the weight change, the physical activity, the dietary behavior. They're just monitoring that, and then they're providing recommendations, and then looking at the outcome of these interventions, and then modifying those interventions to try to give the individual the best advice over time. So they learn, they adjust, and they give the patient continuous feedback that changes. And so that's quite interesting and could ultimately lead to good outcomes as well. And last slide here, talking about some of the interesting things being developed, this sort of genomic and microbiome profiling. This is basically taking sequencing the DNA or looking at the microbiome profile, putting that into an AI model in order to deliver very personalized obesity treatment. That's being done and studied. There's also this interesting concept of AI digital twin. So basically it's taking healthcare data such as genomics, so the microbiome, lifestyle, clinical information, and using AI and mathematical modeling and creating a digital twin of the individual, and then using that to basically figure out the various therapies and how they would work and how you would modify it based on that sort of model, and creating this personalized approach to the patient. So again, a lot of developments, a lot of interesting things, and I think right now a lot of this is very early. A lot of it is sort of the results are somewhat modest, but I think if you take a lot of these things and incorporate them in models that we're currently using in obesity care, surgery, medicine, dietitians, psychological support, using these as adjuncts, we can really have even better outcomes. So I think the future is certainly quite exciting. So I'm going to leave it at that and wrap it up here. So we can do maybe just a quick 5-minute question Q&A session, and then
Sorry. Able to repeat it.
Yeah, I didn't hear it quite well,
Okay.
sorry.
It sounds like a lot of the negative effects of obesity are tied to inflammation. And if that's the case, why is putting patients on anti-inflammatory meds not a standard part of obesity treatment?
That's a good question. So I think some of the anti-inflammatories we have aren't built for that, first of all, right? And it's a little more complicated than just inflammatory markers. I think they play one component of it. So I think just targeting that would probably miss the whole goal of weight reduction and decreasing pathology. So I think Dr. Ali's major slide that he put up there that gave me PTSD from when I wrote my step 1 exams that shows the different pathways. I think inflammation is one component, but just focusing on that would not solve it. But definitely being looked at, and I think that's what's the exciting part with some of these new drugs that are coming out. They're looking at different pathways that maybe haven't looked at before and targeting them specifically. So we might see something that targets those in the future.
And then this is kind of still on the same topic related. And I don't even know how they looked at, is that inflammation, how much of it is tied to the obesity itself and how much is tied to consumption of like processed foods? Like, I don't even know how easy it would be to be obese if you're not ever eating processed foods, but like, is that inflammation without eating processed food but still being obese still present to the same level?
So I think that maybe some of the difficulty is inflammation is like a giant word. It doesn't just mean one thing. Like in the body, there's like 10 different, like probably more than that, inflammatory pathways that do different things in the body. Some of them are helpful, some of them can become pathologic. So like when we talk about like pain and joint inflammation, that is like one inflammatory pathway. And there's a lot of overlap. So kind of like Dr. C mentioned that slide, there's like a lot of these complicated crisscrossing things. So in obesity, it's like the issue is not, like processed food definitely significantly increases the risk for developing obesity, but the reason why is because those foods tend to be very hyper palatable, like they just taste really good, and they don't give you the same fullness effect that unprocessed food would. So then you get this excess calorie intake, and then you accumulate fat, especially in the viscera, and then that fat in the viscera creates inflammation, which affects the other organs. So the end issue is still like the excess energy balance, but it's kind of like that restaurant example I gave. If no one's in the restaurant, it's not just because no one walked through the door. There's a reason why that's happening. If the restaurant's full, it's not just because 10 people walked in the door. Like that's just the obvious, yes, 10 people walked in the door, but why did they come in the door? So I think that's where we have to try to differentiate that.
I feel the inflammation is not coming from the food, but from the expansion of the fat cells itself. Because that, stimulate the brain as there is injury to the tissue. Because when we have more weight, we have expansion of the adipocyte tissue. And that will activate the immune system. That's another thing.
Yeah, absolutely.
Okay, any other questions? We'll take a couple questions, yeah?
Yes, for Dr. Osman, when you talked about the weight gain in the postpartum women, when would you consider talking about GLP-1s in a postpartum woman who's gained weight?
Yeah, definitely it depends on if they are going to breastfeed. If they are not breastfeeding, because this medication is contraindicated, it transmit. There is no study done on this, right? Because they don't want to try something like that. But if the woman is going to breastfeed, we don't do it. But immediately after they wean, they can start medication.
Good question.
Also a really sensitive time to be talking about losing weight too. So I think that, really having that conversation, the collaborative, what are you looking for? What do you need right now? Because just the amount of stress that a new mom has to start talking about, medications and weight loss when they're not even sleeping and all of this other stuff might be a really challenging time to bring up a subject like that. So.
Yeah, this is not necessarily evidence-based, but this is just like my personal practice. Is I usually, because I sometimes have patients come in. I literally had a patient come in a week after she gave birth. So my counseling to patients is wait for 3 months, like that fourth trimester, whatever you want to call it, and then let's have a conversation. Because like you said, there's a lot of things that are going on in that first 3 months postpartum. So that's just my sort of rule of thumb I try to follow.
But sometimes you start with lifestyle therapy for the first few months, and by that time they will be, not on medication, and they can, you can consider that as well after.
Okay. Any other questions? All right. Well, thanks everybody. Thanks for coming. Sorry we ran a bit behind schedule, but have a great day. Have a great weekend. Thank you so much.